Bwrdd croeso and welcome to our board meeting. I'd like to say a particularly warm welcome to our colleagues from Shadows who've made the journey again today all the way from Ammanford. I wonder if people could all switch their mobile phones off, please. Beautiful, beautiful music. And what I'd like to do today is to bring forward the item on the agenda 3.5, which is the project plan to deliver primary care strategy for the Health Board, which is going to be presented by Jill Patterson. So she can make reference to some of the developments in relation to meeting with Shadows, because I know you've got to leave at the break time for all your commitments back home. So thank you. So if I go straight into the agenda, any apologies for absence?
Yes, Chair, we've got apologies from Steve Moore, Chief Executive, and Professor Phil Clare is acting as Chief Executive of the Board today. We've also got apologies from Andrew Carruthers, and he's been represented by our Director of Secondary Care, Keith Jones, Chair.
Welcome, Keith. Thank you. Any declarations of interest? No. Okay, thank you. And if there are any declarations as the Board continues, please let us know. And I'd like to say a very warm welcome to our new independent member for legal, Michael Imperato. Michael is a very experienced board member and also a very experienced advocate for patients and people in Wales. So welcome to our board, Michael. Thank you. I understand we've had a couple of letters, so I'm going to ask our board secretary to outline those briefly.
Yes, Chair, we've had two questions for the board. The first from the Stroke Association in relation to previous board conversations. And we've also had a letter from our friends and colleagues in Shadows. Both letters will be responded to today and will be available on the website today, and I'll get responses back. I did share quite late last night a response to board members so that everybody has seen them before the board today, Chair.
Many thanks, Chair. So then we go into the agenda. If we can go to the minutes of the public meeting held on the 27th of July. Are there any amendments at all to those minutes? Everybody happy to accept them as a true record? Thank you. If we go to the matters arising from that meeting, are there any issues in the matters arising? Judith?
Yeah, on page 3 of the table of actions, it's item, which starts on page 2, PM 23-125. About halfway down on the progress section on page 3, there's reference to the scan for safety, which is being launched in Bwrdd and then rolled out again across the other sites. I just wanted to query the completion date of December 2024. It feels quite a long time frame for that system to be rolled out.
Thanks, Judith. Anybody able to take that question?
Thanks, Chair. That's my current understanding of the timeline. Judith, I'm happy to take that away and just review and confirm it, but that's the current advance time.
Okay, thank you.
Any other issues? I'd like to raise an issue in relation to the RIF Memorandum of Understanding with the Regional Partnership Board. It's been escalated to the new programme manager who is raising it with local authority partners. Do we have any date when that will finally be completed?
Chair, no, we don't have a date. We're waiting on legal services from one of the local authorities to confirm their position, but that's being picked up through IEG.
Okay, can that come back, please? Because it's
being kept under active review.
Yeah.
Chair, thank you. It was discussed at the IEG meeting this week, and again the concerns raised around the delay in being able to conclude this. I understand that the issues that are now still outstanding are very minor, so there was confidence from the local authority that the current delay relates to that those matters will be concluded now very quickly. So we have asked that this is, we advised it was escalated to the board. It's a matter of concern for us that it continues to be delayed, and it's important for the governance actually of the integrated group and the regional partnership board that it's concluded quickly.
Yeah, thank you. So hopefully by next board it should be concluded. Thank you. Anna.
Thanks, Chair. On page 1 of the table of actions, PM 2386, the issue around advice around ethics to the board, that specific action is completed, but can I propose that we have an updated action to reflect the ongoing work that's been described there, particularly around the board seminar discussion, and that it does come back through board in due course.
Thank you, Anna. And I've also asked during our PADR process with both yourself and Chantel that you were part of those discussions. So thank you. Chantel?
So in relation to an update, and Phil and I we've met with Steve, so we've got another meeting with Steve mid-October when Steve comes back, or the chief executive comes back from his annual leave. But we're also working on a case scenario for the board seminar. So we will involve you, Anna. Thank you.
Thank you. Any other issues?
Just on that last point, I think it's page 5, 23144. I know Health and Safety Committee, but just an update on the September 23 installation of the CCTV cameras. I don't know, Andy.
Yeah, I can provide an update on that. We did receive an update at the Health and Safety Committee meeting in September. We were given assurance that we would see the new cameras. We do have cameras in place, but the new cameras would be installed and it would take a 6 to 8 week period. So I've asked the Director of Digital to give us a further update on the progress across 2 other sites, just to make sure that we've got that signed off and completed.
Thank you.
Thank you. So we can keep that in the action log as well until it's completed. Okay, many thanks. If I briefly go to my report, and then if I go to the Chief Executive's report, we'll go to you, Jill, after that, if that's okay. I'll take my report as read, but firstly, I would like to say a huge thank you to everyone at Withybush and at South Pens hospitals, including kitchen staff, estates managers, executives, nurses, doctors, everyone, for the incredible effort that they have made and the way they have actually delivered, moving so many patients and staff from one hospital to another to keep them safe and to keep ongoing care for them. It's been, a huge effort. What it's highlighted more than anything is that we need our new hospital to be accelerated as soon as possible. Welsh Government are spending good money after bad on short-term repairs at Withybush Hospital, and we really need to spend our money more wisely on a new hospital rather than shoring up a hospital and having to do the same every 6 to 12 months with the consequent disturbance, the possible risk and the cost. So I just want to say a huge thank you to everybody. As you can see in my report, there are so many awards that we have won, and I spent a wonderful afternoon yesterday with staff from right across the health board. Awards from the electric cards to the robotics we're doing, to the ability to enable people to keep themselves well before operations, to the theatre staff. And in my report, I set out the awards, and it's also in the operations update. When you look at the state of our estate, it's absolutely incredible, the innovation and the commitment of all our staff right across Hywel Dda. So congratulations to them all. And finally, this is my last board meeting as chair before I retire on the 31st of October. I'd like to thank each and every board member here today and those before for their support, and everyone in the Hywel Dda family for all they do, for all their service and the kindness that they show every day. It's been really humbling and a huge privilege to be able to serve in my own home region. So diolch yn fawr, everybody. So open to any questions at all on my report. Judith.
Yeah, thank you. Not so much a question, but I would just like to sort of formally really thank you, Maria, for your time as chair. It's been a real honour and privilege to work with you. And I'm also incredibly honoured, and also it'll be a huge challenge to take over for the short period of time. But I'm sure with the support of everybody here, I will do the best I can to carry everything forward. So thank you.
Thanks, Judith. I wish you well. Judith will be acting up till the 1st of April probably because of the process. and Judith's very experienced Vice Chair who acted up between Bernie and myself.
Yeah.
So you're all in very excellent hands. So thank you, Judith. And hopefully we're going through the process of appointing a Vice Chair. So we should have a Vice Chair in place as well, which will enable Judith to focus on the acting Chair's role. So thank you, Judith. Rodri.
Yeah, well, can I also thank you for all your hard work, and also you can see how busy your schedule is. But on the kind of just with that report, one thing I just wanted to just say was, can I just congratulate Glangwili League of Friends. They celebrated their 75th anniversary. I was down there yesterday. 1948 they were established, and they've raised nearly £2 million for the sake of the patients and also the staff in Glangwili. I think that was brilliant. Had a very warm welcome, and I have to say we are lucky of kind of friends like this. And I just want to just say happy birthday to them celebrating their 75th anniversary.
Thank you, Rodri. Thank you very much. Absolutely. Maynard.
Thanks, Chair. And again, I emphasise thank you for all the hard work that you've done. Just wanted to actually comment on one of the things in your report, the protecting young children against flu. And from my perspective as the older person champion, I think that's particularly important, where you have so many older people looking after young children, that it protects them as well as the young children themselves. So I think that really needs to be emphasised, the importance of protecting our children against flu.
Absolutely. Thank you. Thank you, Maynard.
Yes, if I may, Chair, there's an award on here that isn't recognised yet, but I'm immensely proud of the maternity services team, the midwives, the obstetricians, the anaesthetists, and everybody who were successful in being awarded the Health Service Journal, improving or creating a positive safety culture within their organisation. There were over 500 applicants, submissions for awards. There were 24 winners, and we were the only ones from Wales to bring back an award. And I think that award is particularly important because it is about creating a positive safety culture, something that you personally have driven, plus as well the work that Lisa and other board members have been able to drive and take forward to create that cultural change that we've led and thought is so important as a board.
Yeah, thanks, Martin. It's an incredible achievement, you know, across the whole of the UK to win that award, and in such an area which is so important. When women are, and families, it's the most, you know, important event of their lives. It's the life and the death, isn't it? So it's fantastic to see. So thank you for that. Any other questions or comments? Lovely. Board happy to accept the recommendation. Thanks, everybody. And now we have the Chief Executive's report. And Phil, you're going to take this. Thank you.
Thank you, Chair. Yes, and this report was prepared by the Chief Executive, so I'm presenting that on his behalf. There's the report, I'm sure, would have been read. A few things just to draw out. One of them is about our escalation status. You'll see there that we have been advised that following the tripartite meeting that our escalation status remains the same, targeted intervention, and we did have a targeted intervention meeting with Welsh Government where we identified we had made good progress on the process measures, and many of those were closed down, but clearly there's a lot more to do on delivery, and I think future meetings will focus on that, and of course that's the focus of our work locally. In terms of the ethics panel, you'll see the terms of reference have been adapted, and we had a conversation earlier about that. And so the only other thing I wanted to draw out, and I know, Chair, you won't want me to dwell on this too much, but I must draw out a few things that the Chief Exec has said, and say thank you to Maria, the Chair, for being a fantastic Chair for the last 4 years. It has been a privilege to work with you, alongside you, and benefit from your wisdom. And just to draw out a few of his words, your quiet strength, tenacity, and kindness. And I think all of those things would resonate really strongly with us. And, you know, I know you're going to cut my microphone off in a minute, but there are a whole load of achievements there. And, you know, I do think, as the Chief Executive said there, you have been absolutely persistent and pushed this ability for staff to feel safe in speaking up. And I think everyone who's met you will have felt really listened to. And I know that's a really key component of compassionate leadership. So thank you for everything that you've done over the last 4 years for our communities, for our population and this board. We will really miss you. And I know all of us will want to wish you well in the future. And you live in this area, so I know you'll be watching us in the background as a critical friend and probably, well, hopefully a cheerleader when we're doing things right. So, and Judith, look forward to working with you whilst you take over the reins shortly. So thank you, Chair. And there's a couple of things we need to endorse and approve.
Thanks. Thank you, Phil. Any questions for Phil? Okay, everyone happy to endorse, to accept the recommendations? Many thanks. Thanks, everybody. I'm now going to go on to Jill's report, which is item 3.5, and if Jill can kindly refer to our colleagues who are present today. Thank you.
Thank you, Chair. But before I do that, again, you know, there's going to be lots of thank yous today, I think, because one of the things you've been a great advocate for is the development of a primary care and community strategy. And I think, you know, when you were talking in the introduction about the urgent need for a new hospital, you've really recognised as well the need for us to be able to develop robust and resilient primary and community services. And what you've also advocated is an organisation that listens. And, you know, want to welcome our colleagues from Shadows again today and to confirm to you that we are listening. And one of the important elements of our strategy is about engaging with our communities and understanding the needs of the local population. And you'll see within the document that whilst we talk about primary care contractor services, one of the things that I'm bringing to the board today for agreement is about that scope. And we know that if we focus simply on those independent contractor services, which are absolutely essential, GPs, optometrists, community pharmacists and dentists, we could develop a strategy around that. But our contractor services are so intricately involved and engaged with our wider community that it would be very difficult and probably quite foolish actually to try to develop a strategy that concerned our contractor services alone. And so what we are proposing today is that we bring forward a strategy that does incorporate that wider primary and community vision. And as part of that, we will be engaging with a listening exercise with our communities, because as part of what we call accelerated cluster development, which is part of the strategic programme for Wales, the role of the cluster with which you're familiar in Am Gwendraeth is one of the building blocks. There are 64 clusters across Wales, and we have 7 within the Health Board. And there's an expectation that they develop a population needs assessment. The resources that then they have at that local level must be directed to the needs of that local cluster. And it's something that the regional partnership board also now has a level of oversight on, to make sure that the resources that we have within our health board and within our local clusters are directed to the needs of those local population. And our clusters come together with a pan-cluster planning group, so we meet with partner organisations to think ahead around the services that we need and how we bring together the resources to meet those needs. We know that we've got a lot of listening to do, and actually when we talked with our planning colleagues around the development of the strategy, we realised that it's probably going to take us quite a lot longer than we initially thought. We had hoped that we would be able to bring perhaps back a finished product to our January board, but actually if we're going to do this properly and get this right so that we have those services in place for the next 8 to 10 years at least before we get a new hospital, we need to get those services right. It's going to take us longer if we're going to talk to our professionals and to talk to our communities around the services that we need. Now, I know you'll be saying to me, well, actually, we've told you, because when we go out to talk to our public about a range of different things, we often hear a lot about those things that are directly important to you in your local communities, how you access services that are as close as possible to home, where your GP is going to be, how you're going to access your dental appointment, but also what can happen within your local community. How can your community be involved in the delivery of services? So we know that we could jump to a solution now, but it would be wrong for us to presume that we understand what the needs and that design looks like for the future. So we will be working with our communities in the design and development of the strategy. And what we've set out for the board today is the sort of level of scope and vision that we've got to consider within that development process. We have also included, probably without exact timelines, an idea on page 7 of the sort of process that we would be working through. And that's in line with other services that we're considering under our clinical services plan. Because actually primary care has also been recognised as having challenges within sustainability. So having the right workforce and understanding the challenges that we face in delivering our services. So what I want to be able to bring to you today, Chair, is a document that sets out the plan. We have included the scope and vision that we believe we should cover. It should be primary and community services. We've given an indication of the things that we know that we'll need to address around the estate, around our workforce, sustainability, and how we also empower our local citizens and communities to work with us in terms of the development of those robust and resilient models for the future. So I do want to bring this to you today, Chair, for the recommendation to the board. We're expecting at the next stage of this that it will be an issues paper coming back to the board in December, which we would then be taking out for further engagement to our communities and to our professionals in terms of helping us design the key elements and the building blocks of that strategy going forward. But just moving back then to the particular issues around that Shadows have raised with us. We're going to be sending you a written response to the issues that you've raised within the letter that you have sent to us. It's quite a detailed letter. And one of the things that I know that we've discussed with you previously is that we have a lot of priorities within our communities. Our clusters have resources that they are given to spend, which are recurrent, but they must be spent within year. They have to consider the priorities that are available to them. And there's never ever a guarantee, unfortunately, about long-term funding. So I know that we've been able to give you some ideas about accessing further sources of funding, which we hope that you'll take up. But we know also that we're going to be meeting with you within October. I've seen some of the dates that I know I've communicated with Councillor Madge and Joyce Watson with. So we're hoping to get that visit and that meeting set up within the next couple of weeks. And we'll look forward to having a further discussion with you around the details and the concerns that you have. But I just wanted to assure you that we are listening to you and the issues that you've raised. And we want to address those in the context of our ability to do so within the resources that we've got and to make sure that we're following an appropriate process. But hopefully we'll be able to work with you around how we can assist you with accessing future opportunities to move your service forward.
Thank you, Jill. Thank you. Any questions on the primary and community care strategy? Maynard.
Thank you, Chair. Yeah, Jill, I just think this is a piece of work that's very much needed. And it's comments, I think, more than questions. When you look at the figures at the early part of it, we have more locum GPs than we do have a full-time equivalent GPs. And only and 75% of our population don't have regular access to dental services. I think that just emphasises the need for looking in detail at this area. One final question. I think I heard you say the draft strategy is coming to the board in January.
What we want,
to bring in Jerry, apologies Maynard, will be, and if you look at the diagram on page 7, it's an idea of the issues that we were to take out for further discussion to the public. I mean, we know some of those and also to discuss with stakeholders, but it's actually firming up what we think some of those models will look like. Services have changed and post-COVID they've changed, but also there are different opportunities now for bringing services together in a different way, and clusters can assist with that. It's very much focused on the multi-professional team, not always seeing the GP, it'll be other individuals that are available, there are different contracting mechanisms. So we'll be bringing together more detail than we've got here around the scope of issues we'd like to take out to discuss with contractors, with stakeholders and the public, so that we get some clarity around those things that will finally go into the strategy.
Okay, thank you.
Thank you. I'm going to bring in Anna, then Chantal, and then Michael. So, sorry, Judith first. Judith, Anna, Chantal, and Michael. Judith.
Thank you. Jill, thank you for the paper and also for explaining the widening scope, which I really welcome. I suppose one thing I would like to understand is how you widen this to look at what's currently within the secondary care sector that actually could be delivered within the primary and community sector. I would include the mental health services in that. We know we have primary mental health services, but obviously there's also the secondary care based, but also our current model for acute services is very much around that hospital base. And I've talked to GPs over the years I've been here, and they all have views about how that could change. So I just would like you to explain where that interface is going to come, so that the people who currently work within secondary care, they can engage, because their roles may change and their base may change in terms of where they deliver that service in the future.
It's interesting, and I guess we've got development going on at different levels probably across our system, and for many years some clusters have engaged very effectively with their secondary care colleagues, and secondary care colleagues do attend some of those locality meetings. But just by way of interest, Keith and I attended a meeting this week, which was a whole Pembrokeshire system model. And we had individuals there from right across the system talking about the development of services for the future. It was very refreshing, actually. And one of the issues, and we talked about it earlier in Maria's report, you referenced it, what has been the development that's occurred as a consequence of RAC, but not solely because of RAC, and where there has been a significant change, probably actually in response to the transforming urgent and emergency care work initially. That has propelled the need to think very differently about services. So I know that our primary care colleagues have welcomed the opportunity for further engagement. I think there's always the anxiety and concern that actually primary care since last September have been at 100% capacity, switched on back post-COVID, and there's a concern that the capacity may not be there to do more. But that's why we've got to work differently. And it won't be about primary care as it is now absorbing all of those services. It will be about, as you indicated, colleagues from across the system working in different places and delivering services in a different way. So I would expect that we're going to be having some of those whole system conversations to enable that work to progress further. We do have examples where there are for different professionals. We now have, as you know, independent prescribing optometrists who work very closely with our ophthalmologists in secondary care. That work's been going on for a number of years. We've seen a lot of pathways develop, and just for everyone to note that 21st of October is the go-live date for the new optometric contract, first in Wales. And then we have got a lot of pathways, of course, with our community pharmacists, a lot of enhanced services now that actually previously you might have seen in the hospital, at least perhaps even in general practice. We've got urgent access in terms of dental services, again, which you may have seen previously in hospitals. So a lot of examples where we have got those pathways working. And I look forward actually to our next board seminar where we will talk about some of the new roles and pathways, and also think more around how clusters in our community are already starting some of that journey. But thank you for raising it. It's a really important point.
Thank you.
Anna.
Yes, thanks, Chair. My question really builds on Judith's, I think, sort of exploration as to the potential for innovation in this, Jill. And you've drawn attention to the, the distinct contractual environment within which primary care operates, and I guess there's a potential there that it is more transactional. So I'm wondering how we can incentivise that collaboration, that innovation across independent contractors, to take that sort of community-based, population-based approach that we would advocate, so that it's not reliant on the particular, discretionary effort of individual independent contractors who are prepared to engage, but it's actually part of the contractual accountability that we expect from our colleagues in primary care. And I wonder, as a secondary to that, which is a bit more specific, but nevertheless I hope relevant, the Nuffield Review report, and where does that fit in this thinking, which I think might also link to Judith's point about pulling care out of the hospital environment?
Thank you. Some really important points there, and I think what colleagues may not have picked up, but is really important in that collaborative way of working across contractors and others, is that when once optometry contract goes live in October, all of our contractor professions are mandated through their contract now to work in a cluster. And when a cluster comes together, we've been talking about what are some, and we talk nationally around this, because the benefit of a cluster was meant to bring together all of those voices, including then also those collaboratives that will come together, not because it's contracted, but good practice therapies, nursing and social care, with their communities, to talk about probably common pathways, disease pathways, diabetes. If you think about all of the partners around the table, everyone will have an area they can contribute around diabetes. It could be an age group, children, the elderly, and that's how we want to see planning going forward, but also with a level of quality and safety and governance around it. So there is an absolutely expected effort to try to move people away from their traditional thinking into something that really embraces the opportunity to be creative with the resources we got, that in so meeting the needs of our community. So that's very much the model that we want to see. In addition to that, when we've worked in traditional ways for a long time, it's really important that we use others around us to help us stand back from rushing in with a traditional answer. And, when we go out to test the market for our contracts, for our managed practices, we know that we're going to see some different models coming forward. And whilst we're going to have to absolutely be clear from the quality and safety and the governance perspective, we are going to have to embrace new ways of delivering services. And that could be, for example, APMS contracts, alternative providers of medical services, and other things that will come through in terms of how our communities also want to contribute to the delivery of those care models. Bringing services out of the hospital, helping people to be confident about seeing different individuals within that system, that they may not be a registered practitioner, they could be somebody who's trained very well in the delivery of a service, that will be able to triage and help and support individuals in a different way. So it's extremely important that we do work in that way. From the Nuffield Review, I think they were really keen to see the development of this model going forward. In the brief conversations we had with them, and we would have liked that to have been a lot longer, I think they could see the direction that we wanted to pursue, and welcomed our opportunity to embrace working with our communities, thinking outside the box and thinking how we can deliver services safely to meet the needs of the community and population that we have in rural West Wales, to be honest. And I think we know that we're not always going to have all of the workforce that we would ideally want. And so we've had to think about how we can deliver services differently. But I will, as part of this strategy and with Lee's support and others, will not only want him to speak to Nuffield, but be thinking about what other things worldwide almost can bring fresh thinking to the table that can assist us in really getting the services right for our communities going forward. And this isn't just for now, it's going to be for very many years to come. So we really want to get it right. And for all the board members, you know, your contribution is going to be absolutely key, and our communities are going to be key in helping us get there. Sorry, I've taken a long way to get to that, but I hope I answered the question.
Thank you.
Chantal, then Michael.
Thank you. A lot of the questions that I had have already been asked by my other colleagues, but I was reflecting on what Jill has just said in relation to this innovative alternative model of delivering primary care. And I think it would be good for us to see at further board meetings the actual extent of the scope of practice of how that is going to be delivered within the community. And I did notice, as part and parcel of the paper, that we talked about engaging with the third sector, which I think will be important in the model that you're planning to deliver the primary care. But I think one of the things I didn't notice in the paper is the relationship between that alternative model of care and education and training, and whether there are plans to align what we do as a health board with the way in which we would implement it in the community. Thank you.
Thank you for that, Chantal. And yes, we do make reference in the paper to the work that we're starting through our Primary Care Academy, and the opportunity there to really put education and training at the forefront of this. I think in terms of scope of practice, that's really important. And, you know, when I started within what was the FHSA very, very many years ago as practice nurse advisor, and then worked my way through in terms of nurse director of the Health Authority. You know, at that point, healthcare assistants were very new. They certainly didn't administer injections, and now we have a scope of practice in place. This is just one example where that is common practice, but clearly there is supervision and delegation in place. We've got many examples actually of community services now. I will bring one of my favourite ones forward, our ambulatory clinics delivering really good services around earwax removal. But that along with other things, it's really important in terms of having that opportunity to develop scope of practice. We've also got a lot of advanced practitioners, and we'll be inviting some of those to our board meeting to discuss with us. So you're absolutely right. To do this well, we have to have that foundation of education and training, and we have to have the right governance in place. The understanding of the scope of practice and a clear framework of delegation must be in place. So, you know, delivering that alternative model of care with the community does rely on trust, and also empowering our public, our patients to take a self-management approach in terms of managing their illness, but also being able to understand how they can access care at the lowest level. And not necessarily always looking, as I say, for the pharmacist or the GP, but what alternative services can assist them. So probably making sure that that information, working with our third sector, working with LICE, is set out very well for our communities so that they understand what's immediately available to them outside of some of those statutory services.
Thank you, Jill. And the last two questions are going to be Michael and Rodri.
Thank you, Chair. I want to say this is a very good bit of work. I'm really pleased to see that the Health Board is committing to doing this. And I've been involved in lots of engagement issues. So if you want any help there, the offers there. I just wondered though, and it might be that I'm missing it because I'm kind of new to the party here, but the ultimate timeline, the outcome time of this wasn't entirely clear to me. What is the best guess of that? So we could, because this is so important, it'd be good to kind of track this through really for us IMs.
Yeah, and you know, we did set a timeline initially and we revised it very significantly. So I do appreciate you're absolutely right. You haven't missed anything. I haven't set the final timeline there. I mean, I would like to think that we were bringing our final product back into probably the July, I think, board of next year. I think we said May possibly, but we want a period of time where we do properly go out to engage, and we've got some work to do in terms of thinking about models of care more widely as well. So I didn't want to make any promises that we then had to undo, and so I hope that by the December paper we'll be able to work with our planning colleagues as well to have much more clarity about the timeline. And then, you know, we're going to have to put the resources to it to enable us to stick to that, because this will require a level of resource around planning, engagement, communication, and actually people on the ground to be able to do that. It won't always necessarily all be face to face, but we need to put our effort there, because it's really important that we take the time then to do that properly, and then to understand what we've heard so that we can bring that product back. And that's only going to be the start of it then. Then comes the real difficult job of delivery. So, yeah, thank you. Sorry, you want to come on the same point?
Yeah, just add a point to that. I guess part of the reason, as Jill says, that the timeline isn't set out is because the scope of this could be very narrow or could be very broad. So it was important to get a board discussion and agreement about the general scope of it first, before we then set out on the task of engaging with people and having a wider discussion about what that could mean. And that will obviously then inform the timeline. So I think when we bring it back, we'll be able to be clearer then about that timeline.
Thanks, Lee. And Rodri.
Yeah, thanks. I always remember someone telling me that only 10% of the population experienced the acute services, whereas 90% of the health contacts are within the primary care. Just a couple of things, just regarding you said the resources, but looking at the recommendation, agreeing the scope, community is a huge area. Are we quite clear the parameters and what we're looking at, because just to understand it clearly, because the paper, and thank you, but just to make sure that really we need to pick Mrs. Jones up before they get ill. We don't want them in the acute service. We want them to make sure if they're not feeling too well, we need to pick them up. And I'm just thinking, when it comes to this paper, when it comes to the scoping, are we clear on the community? The paper is clear, but I just want your experience, Jill, and I just want to have that assurance that we are looking at, because when they're going out there, we need to know the parameters, what we're looking at, because it could be a minefield, because there's so many things and so much data that you could look at in different areas. And I just want to get that community services strategy, just make sure that we're clear in what we're looking at.
It's interesting, when you look up the definition of what's a community, you get various versions of, there could be 5 or 3, and it's often about a geographical place or a community, a group of individuals with a common interest. So, we probably will be thinking about our geography, certainly across Hywel Dda and the communities that relate to those geographies. We will work with our county teams in terms of the clusters that fit within there, and be working on that. But we do have to, I think, be careful that we don't go too broadly, even when we're talking about community, because there are some things that aren't necessarily our responsibility to deliver from a health board perspective, and it'll be about how we work with partners within those communities. So I think we will want to set out the wide scope and then narrow what our responsibility might be within that. But I don't want to I don't want to define it too narrowly, but at the same time, it can't be something that just mushrooms and we don't deliver anything. So I'm still struggling with that a little bit, if I'm honest, Rodri, in terms of making sure that this doesn't run away with us. But we want to bring back a product that we can actually properly deliver and that we've got a responsibility for, so that we can commission the work around that going forward. And as I say, it's not necessarily going to be our responsibility to deliver all the services within those communities, but we want to understand what's needed and how those service models can be designed or delivered going forward. They could bring up transport issues, it could bring up issues for the local authority, for individuals around self-care, for community groups that exist now in terms of how we build that resilient bottom-up approach from our communities, as well as then the contractor services that might be delivered, things that we might move out of the hospital differently, and how do we bring that together? And the other thing that I think we need to be open to is that whilst I will want to see, and I'm sure the board will want to see, a framework that operates across Hywel Dda when we go around talking about this, we have to be open to the fact that it will look slightly different in each of our communities as we respond to the different needs. But we must have a common framework and set of principles that we work to. And people often hear me say nationally agreed, locally delivered. So, we will want to work with that common framework across Hywel Dda and design those services within our communities as local as possible. But in the December paper, I will really want to hone down that issue of the scope of what that community model looks like. So I think we'll understand the the breadth, but I also want to understand that it won't necessarily be the NHS who's got to deliver all the things within that community, but we want to design it together.
Thank you.
Jill, following up on that point, are you working closely with the public health team?
Yes, the public health team have been absolutely key to the population needs assessment actually for each of our clusters. And now that our Diana's in place, we've had some interim support for our clusters from the public health team. And I know that our Diana's keen to build that up so that we've got that engagement coming forward with the data that we need to help us think about the specific needs within our communities and how we respond to them. So a key relationship.
If I may just add, Chair, yes, we've had a brief conversation, as Jill refers to. I've only very recently started, but we're very keen to, I think, some of the structures, as highlighted in the paper, would benefit from some clearer public health approach to, particularly to some of the prevention strategies, taking account mostly on the secondary prevention of long-term conditions, but we'll work closely in that with the team. Thanks.
And we don't have a board in December, so do you mean January?
Yes, I do. Apologies, Chair.
No, that's grand. Thank you. I just also want to, have we got the dates? That's great.
Yes, Chair. So there's 4 dates that we're working on in between the 10th and the 31st of October for shadows. Is that?
Yeah.
Sorry. So we've got 4 dates. I'm just trying to get in the diary.
I just want to confirm that we have offered 4 dates between the 10th and the 31st. So the 10th, the 17th, 23rd and the 31st. So hopefully we'll be able to meet shortly. This is an opportunity of a lifetime, this primary and community care strategy. I think we're the first in Wales to do it. And, I think it's really important that that listening and that engagement, because the first paper that I saw, I thought this was very sort of top-down controlled, and it's really good to hear how it's expanded. And it's good that it's going to come back and be more refined, and we're going to have a common framework, and you're going to be working closely with our public health teams, and it's wonderful that you're going to be leading this, Jill, so thank you for that. We spent a lot of time on this, but I think it's important because primary and community care, as Rodri said, 90% of where our population accesses care and support, and sometimes it's not doesn't get the sort of attention that it should have at board level. We tend to focus a lot on acute care. So thank you for that. I look forward to watching in the wings to see how this progresses and engaging as part of the community.
We'll look forward to that community conversation, Chair.
Thank you. So the board's happy to accept the recommendation. That's grand. Thank you very much. So if we go back to the agenda, and the next is the report of the Audit and Risk Assurance Committee.
Right, thank you, Chair. Well, firstly, if you look at the first one on the agenda, the meeting held on the 26th of July, I take it as read, and the year-end documentation, all documentation relating to the year-end was approved for onward ratification to the board on the 27th of July 23. Shall I go on to the next one?
Yes, please. Unless anyone's got any comments or questions. No, that's grand. Thank you.
Okay. And the same with the other paper then. And this summarises the work of the Audit and Risk Assurance Committee on its meeting held on the 15th of August 23. You can see the different points covered. And I will just come to the last page where firstly you can see there's an appendix there. Which is a scheme of delegation. Therefore, before I go to that recommendation, just a couple of concerns. Concern in relation to the figures, to the findings of the Strategic Governance Update and Savings Governance Review, which aligns with the findings of the Strategic Change Programme Governance Internal Audit previously conducted. The management response would be updated to reflect discussions, and the recommendations would be added to the audit tracker. A further internal audit review would take place within the current financial year, and concerns around the situation whereby benefits had been potentially overclaimed by the Health Board in its role as appointee for certain patients in the mental health and learning disabilities, and that has been addressed. The Directorate will be requested to provide a report outlining processes going forward with an internal audit being undertaken in the current financial year. And then the concerns in respect of contracts awarded and procurement processes, including lack of board oversight and the potential for conflict of interest. A further update paper will be brought to the October 23 ARAC meeting. And in addition to the items scheduled to be reviewed as part of the committee's work programme following the progress of the various actions identified above will be undertaken. As you can see, we are stringent. We looked at things in detail, and it's important. That's our job as a committee. And just back to the changes to the scheme of delegation, which is appended there, that is down for approval.
Thank you. Are the board happy to approve the scheme of delegation? Thank you. And thank you for raising those concerns and assuring that they're going to be continue to be scrutinised by audit committee. So thank you. Thank you. Any other questions? Thank you, Rodri. Sorry, Chantal?
Yes,
excuse me.
I was just, in fact, because I'm not quite sure around what's meant by being the benefits being potentially overclaimed by the health board in relation to the mental health directorate. I'm just wondering whether there were any negative or positive impact as a result of it being overstated, and whether that would have been dealt with by Anna's committee in terms of an issue in relation to CUSAC.
Thanks. I'll bring in Mandy if I may.
Yeah, just to confirm that this issue actually has been discussed with both Andrew Carruthers and myself, together with a legal representative from our organisation. It was an issue that was identified a little while ago, and the team have been working through legal and risk support as well to make sure that the way in which patients are able to claim benefits, it's a very specific case, there are about 3 patients that are involved, is actually worked through, and it was agreed following, because there are a number of options for us to take in terms of the existing patients, and also to avoid becoming the guardian or appointed person to support the management of these benefits. So there's some further work that the team were asked to go back and bring back to me, so that we could then decide next steps, but also to make sure that there were no concerns going forward for any new patients. So we can pick it up, we can bring some assurance back. I'm not sure whether it's a quality safety matter. I think it's more of a financial governance matter, which is where it probably sits through one of Hugh's various meetings.
Okay, so let's go back to ARAC.
Yeah, we'll pick it up through ARAC.
That's fine.
I think in that discussion, no patients were negatively impacted on that. So that is your assurance there. And that was a question we asked as well.
Okay, that's lovely. Thank you very much. Thanks, Rodri. So the next item on the agenda is the Quality, Safety and Experience Committee, and that's Anna.
Thank you, Chair. So the report is a detailed summary of our meeting last month. All issues stand. I'll just draw attention to a couple of things. The first is that we took an item to review our EQUIP programme, which is our Quality Improvement in Practice programme, which has been running for 5 years. So important to note and celebrate that. I think we've done some really exciting, innovative stuff through there, and our involvement now in the All Wales Safe Care Collaborative shows what benefit there is on getting on the front foot with our quality improvement work. So it was great to see that at the meeting, and the challenge that we gave back to EQUIP through Mandy Davis was really to step up a gear in terms of aligning the work of EQUIP alongside the quality and safety priorities of the organisation. Which feels like the natural next step in terms of its development. So we've asked Mandy to go away and think about how we get that alignment to be tighter than it has been in the early years, where our goal has been simply to engage people in the work wherever the energy was for it. So that's an exciting development, and no doubt I will update the board in due course as that develops further. On key risks and issues on page 6, the final page of the report, those issues stand. All of those will and are being monitored through further conversations in the committee. I just will highlight the final one around ultrasound services, and I think I highlight that one really just to reflect that it is so important in our Quality and Safety Committee to think not only about the service risks in terms of service continuity, but also to understand the clinical consequences for patients as a result of those service risks. And sometimes it's easy for us to get stuck in the service bit and not really get into the clinical consequences for patients. So we've taken this really as an opportunity to reflect on that and ensure that we really strengthen our efforts on understanding the clinical consequences for patients, which is ultimately what the committee is there to do. And finally, Chair, just to recognise, as so many have this morning, your support for our committee, for its business, for your common sense, straightforward approach that I am really going to miss. And your straightforwardness in dealing with issues where they need to be called out and tackled. So thank you very much on behalf of the committee.
Thank you. Call being a Scouser.
I was going to mention the Scouse, and I thought, I'm not going to chance my arm on that one.
Chance away. So in relation to the ultrasound, that's going to continue to be monitored at your committee? Yeah.
It will, yes.
Yeah. Okay. Any questions on the quality report?
I just wanted to make a comment in particular because we report the listening and learning subcommittee reports to Anna's committee, and I chair that. And it was really pleasing to see the honesty and the cases that are brought to that particular committee, and the way in which staff are thinking outside of the box in order to make sure that they can implement the learning that they've learned from the cases that they have had to deal with.
Thanks, Chantal. Thank you. And you did share that with me last week. Yes. Very refreshing. Thank you. So the next item on the agenda is the update of the annual plan, and Lee, that's you.
Yeah, yes, thank you. Thank you, Chair. Thank you very much. So I guess the first thing to note in terms of the paper is, I think probably on reflection reading through it, the language in the paper is probably not as clear as I would choose it to be. So apologies to members for that and members of the public who may be reading it, because I think on reflection probably that could have been clear from the outset. So beyond that, what I was going to do is just give a quick summary of where I think we've got to now within the annual plan. I guess it's particularly relating to the financial delivery, which he will pick up obviously in his main finance update as well. So we've established an executive-led core-delivery group now, which is meeting weekly. Lisa is chairing that, and we've that group is supported by a recovery team that we've drawn together from across the organisation. I think board members know we've held a series of workshops with the senior leaders across the organisation, and a significant amount of work is going on to really understand what the options are and the implications are of us reducing spend, variable pay in particular. We've taken that to board seminar previously and into extraordinary board discussion. In addition to the delivery savings, we're also scrutinising all our vacancies that are going through the organisation, particularly admin and clerical, and other costs then like study leave and any other in-year discretionary spend we might have. So we're really having to focus in on any options we may have to delay or stop spend in order to support that position. Unsurprisingly, the delivery of savings is challenging, and not all are achievable without us risking a significant impact on service and quality. So we're obviously avoiding that, but that does limit what we're able to deliver within in year, at least within the savings. But it is at least helping us start to put forward a trajectory of improvement that would extend into next year as well, and that'll lead into next year's plan. Progress is being made, however, and some of that progress I would say is visible within the finance paper that he will take us through that follows. So, for example, the revenue deficit trajectory on page 137 of the board book does show that our costs were increasing up to June. Since July, we've seen an improving trajectory, and we expect that to continue to year end. In addition, there's an improvement in the savings forecast as well. So I think we are seeing signs of improvement. I guess what is also true, though, is that you can see from what that looks like compared to what we need to deliver, that actually we're not at the point where we're able to deliver the savings and the change in financial spend that we require. One other quick note on that, I also attended, we mentioned the ethics panel earlier, I also attended that to have a general discussion about some of the dilemmas we're facing in these choices, which I think was helpful, and the panel will consider further. The other point that the paper raises is us reflecting on our planning objectives. So we've had that discussion at board previously in board seminar. Given the focus and the amount of attention and effort we need to put into addressing the here and now pressures, what might that mean for our delivery of planning objectives? So we've got an indication in the paper of where we think we would have to prioritise our efforts as an organisation and where it may be necessary to slow on some of those plan objectives. Just to clarify what we mean by that, most of the plan objectives are very broad programmes. So within them, there'll be aspects that we continue to deliver and we expect to deliver as per the time scales that we'd set out originally, but there may be some aspects that we over the next few months will need to devote our resources into other areas in order to make the progress I've described, and that may have an impact for some of the timelines. So what we're suggesting is if board are broadly content with the way we approach it as an exec team, then through the committee structures we'll bring some further detail as to what that means for each of those individual planning objectives. So that was all I was going to say, Chair. That just a final point on the recommendation. So we are asking for support for that, what we've set out in terms of planning objectives. The other approval sought was in relation to the 1.5 million savings. On reflection, I think the position has changed since the paper was written. We're not seeking that today. It's more noting the efforts that are going on and the progress that's being made. Okay.
Thank you. Any questions? Chantal?
Just a comment in relation to Lee attending the ethics panel. The panel members on the ethics panel members were very pleased that Lee attended the meeting, and also that he spoke with candour in relation to all of the challenges, which led, I think, a lot of conversations and a lot of papers being shared in order for us to be able to provide support to what the health board, or certainly to what the direction of travel is.
Thank you. Thank you. Winston.
Thank you, Chair. Before I ask the question, just want to convey my thanks to you for your support for me at the Health Board. I think you've been fantastic, Chair, in supporting sustainable resources, and you've had a really great approach of balancing the care of patients and staff with the requirement for financial balance as well. That's much appreciated. And sometimes toning me down in terms of my requirement to get some faster savings. So I'll go on to my question, which is, Lee, I think I kind of welcome the way this report has been put together. I think it demonstrates that the Health Board is trying its level best to make the savings it can do. But I can only conclude that we're not quite doing it quick enough. I mean, we've been set a really challenging target by the Welsh Government to get to not just £113 million, which is our plan, but now to about £101 million, which is their ask. And I think what you've set out, I think on page 4, which is page 123, where you've looked at 9 areas to look at the scope for further savings, further opportunities. And when you've looked at those again, they started at 3.4 going down to 1.5. I think my conclusion looking at that was we actually need to look further and wider than that, as challenging as that may be, because we do have that statutory requirement to break even, which we're not clearly going to do this year. But I'm more thinking on the longer term. We may not do that this year, but we need to start to make steps for getting to a position where we can see financial balance in the future. So my question is about encouraging the things we do this year and thinking of the future. How are we going to go about that? And I think also that you alluded to the fact that the position's moved on from here. I'd like to see what an update is, if you can, as to whether it's yourself or Hugh, as to what that position is looking like at the moment.
Thank you, Winston. Hugh or Lee, or both?
Yeah, happy to come back in.
Yeah.
Chair, I would agree with the challenge which Winston has set out there. Ultimately, what is driving the financial position this year is our use of agency staff, medical and nursing in particular, inflation in drugs, and CHC. And in terms of the areas which are sufficiently variable and have sufficient flexibility in them, I would suggest that the only real area of magnitude is to refocus in on agency costs across the health board. So that's the area that has been the focus through the core delivery group, which Lisa chairs. And at this point in time, of the opportunity that was brought to the board in August, that £26.6 million of gross opportunity, 2 million has now become much more assured and part of our trajectory and plan. Some risk around that, but is in there. And there is further work to do to provide better assurance that the remainder can be translated from a broad opportunity into something much more specific and deliverable. We're not at that stage yet, and that's the challenge for us.
Thank you. I'm going to bring in Lisa as well, if I may.
Thank you, Chair. I think one of the things to point out, biggest cost are staff costs. And it's really important that Wales Audit Office produced a report that was published this week. We will be talking about it through our People Committee, but in that report, it showed that Hywel Dda had the lowest turnover in NHS Wales. It had the second lowest sickness absence rates compared to one other large health board in Wales. We also had the lowest pay costs. So actually, the work that we've been doing over the last few years has got us to the position that we're at now, which means where we've got places to go are fewer, because we've actually been driving the efficiency for quite some time now. So just to give assurance, we have got other things that we are working on through the CDG, but we are not pressing any buttons on making any changes if they have significant impact on our staff or our patients. So we are really robust through our quality framework, and Mandy is on the group to help us through that we are sure that we can deliver the programme. Some of the areas where there has been slippage has been because there have been some recruitment delays. So the plans are there, they're still going to happen. It's just slipped by a few weeks. So we are very much looking at every case. We are developing new programmes, but just recognising in that audit report how far we have come already.
Yeah, thanks, Lisa. That's really important. Thank you. Judith. Sorry, Winston, excuse me. Winston,
I just wondered, so my question was also about the longer term.
Yeah,
about what we're making some steps towards that, because what I've heard is great in terms of what we're doing in short term. I think it's really important that we think about the medium term as well, because effectively this year, we're going to land where we're going to land to.
Yeah.
And where we can really make the difference is next year and beyond.
Yeah.
I
think what you're seeking is assurance. We've got the reality of this year and we are improving. I think what you're seeking is assurance that we will continue to improve this year and that we will meet our targets in the next year. Is that what you're seeking?
Yeah, I think it's going to be challenging to meet the targets in the next year, but I just want to see the trajectory of improvement if that's possible.
Okay.
Acknowledging that what our colleagues have said in terms of inflation and the other pressures that this health board and others are under.
I saw Hugh nod next to you. Yeah, okay. Judith.
Thank you. Lee, first of all, thank you for the remarks at the start of the paper. I have to admit, I found this quite incomprehensible to read. And I think it's such an important area. And I think the language of these papers that the public can access easily is important. So thank you for saying that. And I'm sure next iterations will make that a bit clearer. I have two specific points, if I may. On page 5, there's a table here which talks about things being prioritised, slowing or pausing. I suppose I just want to understand, and particularly based on previous conversation about the primary and community care strategy, we talk about slowing the engagement and listening to people and pausing continuous engagement. So I would like to understand what that actually means in practice. And then my second point, which is more a point, if I may, on page 6, there's some very positive results in relation to mental health services, which are there, but I do have a little bit of an issue of saying that 17.5% of children are waiting under 26 weeks, which means that 82.5% of children are waiting more than 26 weeks for a ASD assessment, and 66.3% are waiting more than that time for ADHD. I know the detail of that and I know the reasons why, but I just think it's important the way we we just publicise these things and state them, because while there's huge successes in that paragraph, there's also things that we've still got to work on. So that was just a general comment. But I'm particularly interested in the meaning around the slowing and pausing on page 5.
Thanks, Judith.
Yeah, I'll pick up the general, and I think Owen might want to come in on that specifically then. And thanks for the comments about the mental health ones. I guess that paragraph is describing mix of results, isn't it?
Yeah,
so that was intended to show where we haven't got to where we would want to be. So generally speaking, on the planning objectives, as I said, what we've tried to do is really focus on, well, what are the things we have to deliver on in the next 6 months or so in order to support some of the financial recovery we've talked about and other things. So that's where we've identified the prioritised areas. Where we've then talked about potentially pausing or slowing, that doesn't mean we're not going to make any progress in those areas. And if you take the example of continuous engagement, that was a specific planning objective around developing a new way of engaging with our population. Whereas what we're essentially saying is we're probably going to need the teams to be focused on the normal way of engaging, which is involved with the primary care, the clinical services plan, the PEDS work that we've been on. So there's so much engagement that's going on at the moment that we're just going to have to probably prioritise that above establishing a new framework. But Owen may want to add to that.
To be honest, I think Lee has covered all of that, but just to provide reassurance that that yes, it is a case that, as we've seen during the past year, where we've engaged on the site selection and the paediatrics consultation, that was done as part of our business as usual, and going forward it would be the same with the clinical services plan and the primary care work, in the sense of the team would be very much focused on talking and listening to our communities.
Great. Thank you. I just thought, just to be clear about that in the context of the earlier discussions, that's really helpful. Thank you.
I'm going to bring in Maynard and then Anna and Rodri, and then we'll call it to a halt.
Thank you, Chair. Again, I'm referring to the table on page 5. In assessing these and slowing them, have we done, going into a bit more detail, a financial assessment of what the financial impact that might have this year on changing those? And particularly where we aligned a lot of these planning objectives to the ministerial priorities set by Welsh Government. And I'm wondering whether we've looked at the impact of the changing, slowing and pausing of some of these against the delivery against those ministerial priorities. And finally, I do have some concerns that slowing some of these might negatively impact our longer term objectives of transforming care. From my perspective, my background, I'm particularly concerned about the slowing of digital, because I believe digital services have got an incredible ability to actually transform the way we do things, as we saw during COVID.
Happy to respond, Chair. So naturally, all the planning objectives were developed with good intentions behind them, and they're all necessary in different ways. So we're always going to face difficulties in trying to prioritise our efforts, and inevitably we end up in a debate, I guess, to some extent, between short-term requirements and longer-term sustainability. I guess I talk in general terms, I suppose, as much as I can, but where we've talked about potentially slowing in ministerial priority areas, if you take the planned care one, some of that is reflecting where we've got to in the discussions with Welsh Government and around a financial position around the use of the additional planned care monies. And obviously we are experiencing other challenges like the RAC issue as well. So some of the things are probably inevitabilities. To answer your question though about the extent to which we've assessed all of that at this stage, the answer to that is no. We haven't looked at what each of them means in detail with respect to what the new delivery plans would look like, what the financial impacts might be, and so on. That's work that will need to be gone through in each of the individual and specific planning objective areas to understand that. On a point on digital, as take an example, that that's really reflecting the reality of the fact that we have missed some of the dates that we'd already set out for all sorts of reasons, really. So we still see that and many other things as priorities and things we want to progress. But it's just recognising, I suppose, through this process that we've either already slipped on some things or that there's likely to be a need to slip on them later in the year. So I think it's just a reflection of that reality, but the detail of that we'll need to work through and then have the meaningful discussions at committee level about what that means and choices we're going to make.
Thank you. Anna Rodri.
Thanks, Chair. Yes, so the paper, as I read it, sort of focuses on what we have, on the progress we have been able to make, but doesn't take us much further in terms of the gap that still remains. And I guess as we come on to the next item, we'll get more into that. But of those savings we have been able to identify through the CDG, what is it that we're doing now that we were unable to do sooner? And are we taking greater risks in order to be able to do those things now?
Yeah. So the things that we are doing now are very much linked in with the reduction of agency workers. So it's about, for a number of those schemes, it's around the targeted approach to our recruitment plans, which will then help remove that high cost agency worker. So there are a number of schemes in place that are linked with that. There are some which will be linked with how we deploy some of our workforce. So we reduce vacancies, and by reducing vacancies, again, that will reduce variable pay. So we've become a more efficient organisation in a number of areas. And there are some things that we're looking at around if we were to look at our patients differently in our skill mixes in terms of the care that we need to provide for them, what will that give us? In terms of are we taking any risks with that, through the quality impact assessments, we are looking at what is the risk of doing it. And of course, if we continue to drive agency rates further down and we still have patients in beds who need the care, then that will create risk. So we've been really clear that we're not enacting any of those until we're certain that, you know, we aren't exposing anybody to any further risk. The next place that we have to go is to further try to encourage our agency workers to become our employees. And we have started to see some of that shift where some of that high cost agency workers have now either moved on to an alternative framework agency or indeed have become members of staff. So it's about progressing those in a much more targeted way. So by having the team that are supporting the services, we are able to have someone from recruitment, someone from the bank office, someone from planning, so that we can actually enact a series of change rather than a scattergun approach of trying to fix everything in one go. So that's the approach that we're taking at the moment. And the quality impact assessments, I think, are scheduled to come to the Quality and Safety Committee shortly.
I've been picking up on Anna's question is why haven't we done it before? Andy.
If I can just add, and I don't know whether I'll answer this question or not, I think what's really important is, and as Lisa has said, we're quality impact assessing anything that doesn't move and does move at the moment. All of the choices that we are presenting and we are having to consider come with a risk. Just because, and I think this is a really important point, just because we do a quality impact assessment, it doesn't mean to say we're not going to have to do something. Or everything we are doing will come with a degree of risk. And this is where the board, I think, is going to have to be really clear about the level of risk that we will have to run with if we are going to save the level of money that is being identified here. So all of our choices and all of our actions come with a risk. I think for me, the quality impact assessments enable us to be transparent about the decision making and the risk that we are then putting before people to acknowledge it's not without risk. It's not without impacting upon patient experience. So I will sit here and tell you now that I expect that we will see more complaints because we are going to have to make decisions about reducing, restricting, changing the way we do things that are not going to meet people's expectations, both our staff and our patients and wider population. And I think when we look at things that we're talking about, particularly on page 5 in the table about what will slow, what will prioritise, some of it, so if I look at infection prevention control, bit biased, sorry, I lead on that area, so I'll just mention that one. It's a no-brainer almost to not take forward work on infection prevention control, because that has a direct impact, not just upon the outcome of the health and well-being of our population, our staff, but actually has a direct impact on the number of patients that we have sitting in beds or consuming, and I'm sorry I use that expression, consuming healthcare and services that if we were able to reduce infection, they would not be needing. There are other things, however, and as Lee has articulated, and as Lisa has indicated, with the control group that we've established, we've taken staff away from their day job to do that work. So some of the things that we're having to slow down now is because we've had to create a resource to enable us to find the savings. So some of, and particularly the corporate functions, are no longer able to do everything that they were previously doing. They are now focused on wrapping support around both operational services and also other functions. Yes, we're looking at the quality impact assessment, but everything that we're being asked to do by Welsh Government and the decisions we are taking come with a degree of an impact. So I just need to be really clear about that. Why haven't we done it sooner? I think because, as Lee indicated, we have set out as a board, we're really ambitious. We want to drive a set of standards, quality, kindness, compassion, and that is our trademark. But we're having to rethink about which bits of whatever we're doing, do we stop or do we change the pace of, without stopping about being kind, caring and compassionate, because that is what we are about, and we will continue to always maintain patient safety. But I think that's the honest conversation we need to have. So sorry for a bit of a rant, but I think it is really important. Everything we're doing comes with a risk.
Thanks, Mandy. I think Mandy's, sort of explanation there, which I don't consider to be a rant at all. I think it's a very straightforward way, and this is exactly the kind of conversation the board needs to get into and needs to be absolutely clear about, is that actually the environment does drive us to take greater risks. They're not uncalculated risks, they are not reckless risks, but our risk appetite is having to change because of the financial environment we find ourselves in. And we must do that openly, we must do it consistently, and that loops us full circle back to my hobby horse about the ethical component of the decisions that we are making, not simply at an individual patient care or service delivery level, but at a population-based level where we are making choices about priorities between different cohorts of patient need. So I think this is exactly the conversation this board should be having in the open and with our public, to really drive home just how significant this challenge is and the choices we are having to make in order to land a control total that is where it has been placed by Welsh Government. So I would encourage these conversations. Let's not call them rants, let's call them straightforward, difficult stuff that is in the business of this board to get into, because if we're not doing it, no one's doing it.
Okay. I'm going to bring Chantel in on this particular topic, and then I'll go to Rodri.
Thank you, and thank you, Anna, for raising and articulating the issue around risk and impact, and the fact that these are the conversations that should be coming to the ethics panel in order for us to be reassured that when we are taking those risks, that we are looking at the impact and how that would affect not only individual patients, but also the communities that we're serving. And I think it's something that we can take outside of this forum, but it is something that we should really be focusing on.
Thank you. Rodri.
Yeah, I think we're between a rock and a hard place, aren't we? We have to find those savings. And as has already been said, just a couple of things. Firstly, Mandy, Lee, thank you for that assurance that the quality and their quality impact assessment has been done on those. It does say that in the paper. Two things, Welsh language and culture to be confirmed, and also, is this table going to grow in the next couple of months?
I may need to comment on the Welsh language and culture. We haven't actually had a discussion about that one. That's why it's to be confirmed.
Oh, right, so, okay. Just regarding...
It doesn't, there's no division. The table won't grow because these are all our plan objectives, but naturally, I guess it could develop. But I suppose really the purpose of the task was to consider what the next 6 months might look like, and we'll be embarking shortly on our planning cycle for next year, where we'll start to have similar discussions about what is our capacity next year to deal with, to deliver all the things we might aspire to deliver in terms of progressing our strategic vision for Mid and West Wales, versus the imperatives to improve our financial position over the next sort of 12 months or so. So that will be the discussion, I think, in the coming months.
You final word?
Yeah, Chair. Just reflecting on some of the conversation, why haven't we been able to do this before now? I think is because it's very difficult to do. And if I just reflect a little bit on some areas of success that we haven't celebrated particularly, but have demonstrated better value for the system. We had a presentation at Core Delivery Group last week, the week before, from the value-based healthcare team around heart failure, and an investment in the community of about 600,000 to stabilise patients earlier, to identify patients earlier, has made a big difference to the tune of 1.7, 1.8 million in terms of the avoided demand in secondary care. Of course, that demand has that benefit hasn't been cashed out as a saving because it's been taken over by other demands that have impacted us on the system. So we're seeing that growing demand, and as much as we try and mitigate that with investments in the community, there is still a growing demand from other causes. So that's part of the challenge. But the issue that we're fundamentally facing is that we're trying to deal with the consequences, of our fundamental issue, not the fundamental issue itself, which is flow of patients through our system. Now, as we sit here today, there's about 250 patients waiting for something within our beds. 150 roughly of those patients are waiting to leave through a package in the community, through a social care package, through a health package in the community. That's a fundamental driver of our cost. At a substantively staffed bed-based cost, that would be between 15 and 18 million pounds. But of course, that is where much of our agency pressure is going as well. So addressing that issue would address the demand for nurses, and addressing that would make a very significant inroad into our financial deficit this year.
Thank you. Lee?
One very fine point just on that question of why haven't we been able to do some of these things earlier. I guess if you take the two largest examples, which is the reduction of the off-contract agency, or almost eradication of it, and the bed reduction we've seen in the Pembrokeshire system, which has been associated with obviously the RAC changes, but has only been enabled because of the changes in pathways of care. They are the direct consequences of some of the things that we've been working on for the last 12 to 18 months. So the international recruitment is the only reason we're able to function without those off-contract agents. Work that's been done on TUEC and transformative emergency care and so on has enabled us to function without some of the beds. So they've always been in the pipeline, if you like, but some of them have been accelerated now and pushed over the line. I guess it does underline the need for us to continue to think that bit further ahead as well, though. We've got to be thinking 12, 18 months ahead in order to allow us to have those benefits in future years as well.
Thank you. Okay, thanks everybody. I'm going to go to the recommendations. So we note the efforts to deliver the 1.5 million run rate reductions, and is the board happy to approve the changes to the planning objectives? I'd like you to bear in mind that when we approve the changes, it'll mean a change to the committee's work programmes, as we won't be seeking assurance as often in relation to some of them. Is everybody happy with that? It's a really difficult time for every health board in Wales, and I expect it's for every health organisation in England, Scotland and Northern Ireland as well. It's good to hear about the retention and the sickness, which has been the result of a long piece of work, that we are so low in both. I think it's important as well, Alwena, I'm out there and a lot of the staff don't understand the reasons why, in relation to the staffing, etc., they're being asked to consider their budgets, etc. They just don't know the story. So I think we've got to continue with that communication across our organisation. It's not a top-down imposition. It's the reality of the financial position everybody in Wales finds themselves in. And I think it was really assuring to hear the why we haven't done it so far, and this is all carrying a risk. And when we go into the next paper, I'm sure there'll be a recommendation for something very important to go to the Ethics Committee, as you raised. So thanks, everyone. I'm going to call a 10-minute break so our colleagues can travel back home to all the responsibilities. I said I'd try and call that at 11 o'clock. And it's 11 o'clock, so another miracle. Thank you so much for coming. It makes a difference, and it actually does reinforce what you're saying by you physically being here. So thank you for that. It does put pressure on the board to engage, and that's what, as you can see, there's a myriad and massive loads of priorities and challenges and pressures, and just seeing you face to face makes a big difference. So thank you, and safe journey back. So we'll have a 10-minute break, everybody. Thank you. Okay, right, so welcome back. If we now go straight into the agenda, and it's 3.2, the financial report, which is very connected to the previous discussion we've just had. Over to you, Hugh.
Diolch, Cadeirydd, and just echo everyone else's comments this morning, Chair, to thank you for your wisdom, support and challenge over your period as Chair. And it's been an incredibly challenging period, and we use challenging all the time in the NHS, but the last, your period as Chair has seen us go through the pandemic and the aftermath of that, and financially delivering value through the pandemic and keeping us true to our duty to the taxpayer as well as our patients and population has been a hallmark of your work with us, and I'm grateful for it. I know that the financial position that we're seeing today isn't where you or any one of us on the board would like to see it at this stage, and I'll just go through some of the challenges that we're facing there, but I think we've already covered many of those issues already. I have restructured the finance report, so you'll see a new format in front of you, which I very much hope makes it easier for the board to navigate, but more importantly, makes it clearer in terms of our role to exercise accountability through the Health Board as well. And this will be replicated through our work with some supplementary information that will be provided to the Sustainable Resources Committee. So you'll see a common format throughout our reporting. Just to remind the board that our plan for the year is a deficit of 112.9 million after delivering savings of 19.5 million. Clearly challenging discussions ongoing nationally given the consequences of this at a national level, and there is a very clear expectation from Welsh Government that we achieve that target and go further. We haven't yet got clarity on how much further, but there is an expectation that we would go further than our plan. But at this point in time, our forecast at month 5 is a deficit of 137.5 million after delivering savings of 7.2 million. So quite a long way adrift from delivering that plan that we set at the start of the year. To say Welsh Government very clear on our expectations, and one of the things that we've held in abeyance within our reserves at this stage is the planned care recovery funding, and that currently is sat within our reserves. We haven't yet deployed that, given the need for clarity on a route to delivering the cash consequences of that deficit. At this point in time, we don't have clarity on that, and we're working through that, and I'll come on to that in the cash flow section. Our forecast, while it's at 137.5 million, has improved significantly in month 5 from 143 million that we had in month 4. That's been largely the result of some of the operational changes and clinical changes that were made in response to the challenges that are well rehearsed down in Pembrokeshire. Planned care activity has reduced, again, because of some of those challenges in Pembrokeshire, and that has given us a financial benefit perversely into the position, as well as some of the energy price reductions that we've seen. Energy and medicines are two of our most volatile area of cost pressures, and in a high inflation environment are particularly volatile. We've seen some of the benefit of that between month 4 and month 5 come into the position. We have seen an improvement in savings delivery due to some of the financial controls and vacancy holds that we've had through the core delivery group and financial control group. They have started to make a difference. So as Lee alluded to earlier, we have seen a couple of months of improvement in our trajectory and a forecast that continues with that improvement. But if you look at the grey line on page 5, we are still a very long way adrift from the trajectory that we would need to achieve in order to get back to 112.9 million. And I would say at this stage, I am struggling to see how that is achievable, given the level of variable pay that we have in the system over the next 6 months is probably insufficient to allow us to close that gap. That gives us a very significant challenge to get back to our position. We need to reassess what our forecast is as part of our month 6 process, and we will be going through that over the next couple of weeks. Not only will we not get back in terms of that current trajectory to the 112.9 million, I can't at this point see that we can get back to an in-month position towards the end of the year that would hit the annual equivalent of that. So it gives us a challenge going into next year as well. At this point in time, there's insufficient assurance. That said, there are 6 months of the year to go, and there are opportunities for us to go further, as we discussed in the planning section. That leads me to the cash forecast on page 5, which at the moment leads to a particular challenge for us following the February pay run. That's when the cash issue hits and we would technically become overdrawn. We're not empowered to become overdrawn. We're not empowered to borrow. So that will be an ongoing dialogue between us and government and how we cover that cash shortfall that we have. Despite the good work of the core delivery group, at this point in time, as I alluded to earlier, only about £2 million of the 26.6 million of opportunities have been translated into reasonably assured schemes of delivery, largely because of the perceived risks to quality and safety that we have discussed. The challenges we've experienced are all as expected, and as I've previously reported, nurse medical agency, mental health, CHC, prescribing and drugs. But the fundamental challenge, as I alluded to earlier, is flow of patients through our system. And in terms of the risks towards the end of the year, the areas of particular concern for me are prescribing. We only have 2 months of data. Data on prescribing is 2 months in arrears. So we only have the first 2 months of data. That is showing a very concerning trend for us. And while that's factored into the forecast, any small variability in that could have quite a big impact on the end of year position. We discussed our focus, but core delivery group, our financial control group, and our directorate improving together meetings are clearly the 3 areas of real focus for us in delivering against our challenge. But Chair, the challenge for us at this point in time is incredibly significant. I can't see a route at this point in time to get back down to that planned level. We'll continue to work on that, but what I need to provide the board with is clarity on exactly what our trajectory is towards the end of the year, so that we can speak clearly and openly with government about the challenge we're facing. We have positioned this with government at this point in time as a risk. That risk is now starting to crystallise to become much more certain as a trajectory for us.
Thank you. And can I say thank you for the new report? It's a massive improvement. It reminds me of the beginning of when we changed the performance report.
Yes.
It really, really is. It's much clearer, so thank you for that. And I know it's work in progress. Can you provide us with assurance that we will continue to improve throughout the rest of this year? I hear what you say to us all about reaching the target and reaching the additional targets, but that continuous improvement this year, can you assure us?
There are choices left to be made. So the trajectory that is included within the plan is an assured trajectory from my business partnering team in working with operational leads. So that is kind of the current baked in trajectory for us. Clearly there are some risks around that. But there are some issues that we have and some choices that we have. For instance, there is a decant ward that would be opened in Withybush later on in the year. I can't remember the date now. If we deal with that and address that as a decant ward and just shift activity, then that trajectory can be maintained. If that becomes additional surge capacity for us because of pressures over winter and all very good reasons why it might be, then clearly that would place that trajectory at significant risk, and we wouldn't achieve it. So there are some choices for us to maintain the discipline that we've been working towards up till this point, towards the end of the financial year now, as those operational pressures over winter inevitably gather.
Thank you. And in respect to the savings, it's good to see there has been an improvement, not as much as we need, but it's really good to see that we are improving. In relation to the savings from RAC, I think it's 2.5 million. Will that continue till the end of the financial year?
So, Chair, this is a result not necessarily of RAC, but of the operational and clinical changes that were put in to make sure that we could maintain safe services in response to that. Yes, they are currently baked into our projections at this point in time. As I say, if additional capacity gets reopened, then that is put at risk. But at this point in time, without that additional capacity in the mix, then yes, that is part of our trajectory.
Okay, thank you. I will open it to questions. With your answers there, the choices that are to be made, I just wondered if there could be a closer connection with the Ethics Committee for advice on those choices, please.
I think that's very sage advice.
It's not just finance. There's a lot of conflicting duties here and a lot of evidence, and we did this through COVID and it was really helpful. Doesn't mean we follow the Ethics Committee, but my concern is that in some of those choices, clarity of the governance of who makes the choices and the advice from the Ethics Committee to take into account during that decision-making process. So in particular, you mentioned planned care. Now, not using planned care monies has a huge potential impact on people who are waiting for their operations, waiting for their care. So there's those two conflicting duties there of balancing the books and caring for people. And I think that would be the best forum to consider that in detail with all the statutory responsibilities and advise. And I'd like clarity on the governance, Joe, going forward about where those decisions are made. Is it purely operational, or are these board decisions as well? I think that's important because we're now in those really tricky, stormy waters of the difficult choices that we will have to make. And rather than being informed after they've been made, I think we should consciously consider as a board the involvement of everybody. Some of them have to be quick, obviously, but something should be more measured. Sorry, I don't usually come straight in with questions, but this is particularly important.
Chair, my concern around that, and I think that's very, very good advice, and my concern around that is that the planned care recovery funding is non-recurrent, and we're reliant on that non-recurrent funding to close that gap. We really need to be focusing on the recurrent opportunities we have to push.
Absolutely.
Out. That's the only way by which we will become financially sustainable.
Yeah.
There is a short-term imperative to secure the cash for this year. Cash is the answer for this year for us. But long term, it has to be around the recurrent opportunities.
And that's exactly the issue that should be part of the consideration of the Ethics Committee. And I think another part that should be considered by the Ethics Committee is we have delivered on our trajectories right the way along this year and exceeded in some cases. And I had my appraisal with the Minister last week, and she was delighted with that, and I'm really proud of it. So it's whether we can, it's about our promises as well. So it's such a complex issue that I think just stepping aside for a while and having that debate quickly would assist. But sorry, I open it to questions now. Chantal.
Just to comment on the issue around the referral to the Ethics Committee, I'm sure Phil and Anna, because it's a hobby horse, and that we would work with you here in order to be able to articulate exactly what the ethical dilemma is, in order for the panel members to be able to give consideration to it.
Thank you. And Michael.
Yes, Chair. I thought that's a very interesting discussion, which is carried on from the last item, and I think what's coming across to me is this kind of need for a kind of a governance underpinning of some of this. It's either going to be a very, very busy ethics committee, but also, I mean, some of this touches into when a decision is operational and when it's strategic. If it's strategic, we end up then we're into socioeconomic duty, which hasn't been mentioned, and also, when is a service change not a service change, or when is it operational? So I think a takeaway, almost a entirely separate point, might be a kind of some kind of governance, not overly onerous, but something which recognises these issues have to be exactly as you said, Chair, almost before the decision is done. That's the issue here. But can I just start? That was an observation. But a question I have is, Just on the, but going forward, I appreciate the big issue is, one of the big issues is how we are able to find savings. So setting aside all that governance framework and equality issues and stuff like that, going back to the mechanics of finding the savings, what are other health boards doing? Are there any ideas or methods that we can be tapping into, or are we kind of doing it off our own back, or are there other? Because everyone's got the same challenge, and I just wonder, are we looking out beyond Hywel Dda to see what other people are doing? Are there good ideas out there which we could be adopting? And we've got to adopt these things pretty quickly, because of course we're already now entering the second half of the year pretty soon. Thank you.
Hugh, do you want to answer that?
Thank you, Chair. And yes, in terms of, I guess I'd start with saying we know our business better than anyone else knows our business, and therefore it's incumbent on us to be identifying opportunities within the health board. You'd expect me to say that. But in terms of work that we're doing nationally, there's an efficiency and value group that meets, that's chaired by the Director General. Phil sits on that group along with Andrew, and ideas are generated in a national space that then there is an expectation that that is taken into a local space for delivery. One example within that would be in-use interventions not normally undertaken, which is being developed as a national framework, and we are adopting that locally. Naturally, a very indirect route to cash on that. If we don't undertake some elements of planned care activity, you're likely to replace that with other planned care activity, so it doesn't directly give a cash benefit but helps with productivity. Biosimilars is the other area, particularly within pharmacy, medicines management. How do we move from branded to generics, and some areas around that. Those are opportunities that are being fed into our local framework and then being embedded within our local work. All of these make a contribution, but they're not making the contribution at the scale at which we need to see change within the health board, because fundamentally we have challenges of flow and configuration of services, given our services are spread over 4 DGHs. Those are the fundamental challenges that we're dealing with.
And if I could add to that, all the chairs have shared with the NHS, confirmed all the different things that are being considered in each health board, both orally and in writing. And I know chief executives as well as DOFs have as well. But as Hugh says, every area is different. And fundamentally, I think ours would be a lot easier if we had that new hospital and we had that critical mass in one place, rather than 4 front doors, plus obviously the discharge issues. So I'm going to go through, because people have indicated Winston, Judith and Delith.
Thank you, Chair. Can you hear me?
Yes.
Great stuff. So firstly, I just want to comment on the report itself, which is that, like yourself, Chair, I've welcomed the new format. I think it really provides some good indicators, particularly like page 6, where you've got 12 boxes and you've indicated them red, amber, whatever. I think it's really, really helpful, for example, for us to see the totality of agency and local spending, totality of primary care prescribing, secondary care drugs, what the savings delivery forecast is going to be. I think that's particularly helpful here, so thanks for that. And I also liked page 5, where you're setting out what the revenue deficit trajectories are, the cash flow position, because it really brings attention to the board on that and where the run rate is. Questions? Just to comment on earlier where we talk about the ethics of it. I think if directorates and departments are managing their budgets, if they're really managing their budgets, then they will be having to make tactical decisions about whether they're going to invest in safety, which is number 1 priority, of course, invest in performance, or overspend the budget, state a budget, I think. So it's a way of how do we capture that with its divisional level? How do we capture that and feed that into the ethics panel? Just my point of view, because elsewhere, it's at that level where we'd expect individuals at the senior level to bring those to our attention, because they can manage across a range of services and be able to have some trade-offs, some comfortable ones and some uncomfortable ones. Because otherwise, if we do it at too low a level, then it's just too much detail come through. Just an observation. In terms of the report, Hugh, I think you've been really clear in setting out the health board's position and forecast for the year, which is an improvement, as you said, and some of those improvements have been placed upon us from external factors such as energy and factors we've had to respond to such as RAC and the benefit which Women's and Children's Aid Recovery Plan. I think that's worth commending that they've actually started to make some difference. But nevertheless, I think there are two things that stand out for me. One that you've already alluded to here, which is our run rate, and just checking what our run rate needs to be to get us there. Because I think an emphasis on that month-on-month run rate is really, really important, to be honest, because that is cash out the door. The second thing I want to just pick up on is the savings position, whereby I think you mentioned it, where we've identified, I think it's 11 point, where is it? Yes, it's on that special table on page 6, where you said we've identified 11.4 million, but we're looking to deliver 7.2. So the question really and challenge is, what would it take for us to convert more of the 11.4 to 7.2? One, and two, also, what are we doing towards identifying more than 11.4? You mentioned earlier about the things happening nationally at Welsh Government about savings schemes, but what we've learned in the past is that you can present a number of schemes to divisions or directorates or departments and say, can you do it? And they may not take it up. They may say, well, actually, we don't want to do things here. So we need to just strike an interesting balance between local ownership as well as things coming externally on benchmarking. And I think it's a difficult one to trend, but maybe you can, and others can say more about that.
Thanks, Winston. Hugh.
Yeah, Chair, thank you. So 3 questions, and if I rehearse those, the first one around budget manager responsibility and ownership. I think there are challenges that can be addressed within a budget owner's remit, budget manager's remit, and we would expect those to be addressed. But the challenges that we're seeing are bigger than an individual budget manager can address directly themselves. That's part of the issue we've got with the intransigence of our agency challenge and the intransigence of the flow challenge that we're seeing. So hence there is a challenge there. Operational engagement is rapidly improving. And naturally, while the pressures of COVID have been in place and post-COVID recovery, that engagement hasn't quite been where we would have wanted it to be. That has improved very significantly over the summer months, especially with the 3 workshops that have now been held with colleagues in the operational and clinical space. So that needs to be further nurtured and developed, and we will continue to work on that this year. The second one is, in terms of the run rate reduction, we would need to see a 4 million improvement in our run rate for each month from now on. Now, on the basis that we are already into month 6, we are not seeing that improvement in month 6, and therefore the challenge would become even greater in the following few months of the year. So it's a very significant step change that would be expected. Mathematically, we could get there based on our submission in August, but the delivery of that submission clearly is the challenge for us. And lastly, in terms of the slippage from the 11.4 million of savings identified to 7.2 million, a big element of that was that we were anticipating an 80-bed equivalent saving from, 80-bed equivalent, I would say, saving from TUEC. We haven't, and that was mainly to be seen around the front door. And that saving hasn't materialised given the pressures that the system is under. And therefore, we've not seen the improvement in our financial position, certainly in the ED space, that we had anticipated within our original savings plan. So it comes back largely to around that issue with flow once more. So that's the main driver, Chair.
Thank you. Judith and Mandela.
Yeah, thank you. I was interested in what you said, Hugh, about the this All-Wales approach to looking at efficiency opportunities. But of course, how much you achieve by implementing those efficiencies does depend on your starting point. So my question is, do we have comparative data, as Lisa referred to under the workforce issues, which in our other areas of performance, so whether that's productivity, client care, whether it's the flow issue. And this is not to say, so we use that as an excuse, but it is part of the narrative in terms of explaining to our staff and our public. And in terms of the flow, is there comparative data around where different local authorities are in terms of their ability to help with that? Not again, this is not about saying to any of our local authorities, oh, you're worse than X, Y, and Z or better than, but actually to understand whether there are any particular challenges which are impacting on that. So I suppose I'm talking really broadly about benchmarking data across a lot of these matrix so that we can demonstrate both, look, we are doing a lot because we're starting from here, or saying to the organisation, actually, we're not quite so good on this, so there is scope and there should be scope. Big questions, I don't know if you can answer all of it.
Yeah, so in terms of data nationally, there are a number of sources of data that we use. There is this thing called the Vault that the Finance Performance and Delivery, former Finance Delivery Unit of the NHS Executive hold. We have lots of comparative data in that. There are some areas that where we are generally outliers is because of our configuration. So if I think about women's and children's services, our costs are probably in excess of 7 million, in excess of the average for Wales, because that's because we're keeping services open across a number of sites. So that's a natural driver of our challenge. One of the issues that I want to pick up with the team is how do we build up a story that incorporates those drivers of inefficiency or drivers of cost for us, so we can understand why our configuration is that much more expensive than the rest of Wales. So that's a comparative piece of work, and coming back to your point there, because I think that indicates perhaps the end point we can hope to get to as part of our roadmap to break even, because there are some inherent challenges for us there. And I would say that the allocation formula is population-based, not provider-based. So it doesn't incorporate the effect of configuration of services. It just incorporates the effect of demography in West Wales in terms of the funding that we get. So that's one element. There is perhaps something in terms of the narrative. Yes, there are areas where I think comparatively we have done well as part of our cost growth this year. CHC is an area in particular where our increase in CHC costs are far less than the rest of Wales. But incorporating all of that intelligence and what Lisa alluded to earlier in terms of our workforce intelligence, our run rate is still our run rate. We are still spending in excess of our budget to the tune of 137.5 million this year. So that is still a reality that we're expressing, and I think that's perhaps the challenge that I want to make sure we focus on. The point about local authorities is an interesting one. So we have done some comparative work around a number of things, expenditure on social care by local authorities adjusted for age and demography. So we've done that across the, is it 21 or 22 local authorities in Wales? So we have done that piece of work last year, so we need to refresh that and reassess what that means for us. And also an assessment of council tax rates across each local authority, which clearly is a big variable. And while each year may not be significant, over a cumulative period of about 20 years, I think we looked at, it is very significant. But I don't want to externalise the problem, and it's very easy to look at others as being a driver to our challenge. I think there is more we need to think about as a region coming together through the RPB, through IEG, to address the fundamental issue of flow that we're facing.
Okay, it's really helpful, thank you.
Thank you. Diolch, Cadeirydd. Really building up on that point as well, really, and it's coming down to drug prescribing and primary care prescribing. And we haven't hit winter yet, and I'm just wondering if there is an issue for us, as you've mentioned, Hugh, about trends and about local trends, if there is an issue for us as a cluster level, that there is a need to look at the way that drugs are prescribed, or is there a need to really extend our public health intervention to look at, especially going into winter, about other strategies about keeping our population well? So I just want to find out, do we know the reason? Is it just the drug per head cost, or is there an issue for us about prescribing methods and desires for our medical professionals?
Chair, I may bring Jill in a moment, who knows certainly much more of the detail than I would ever claim to. Primary care prescribing, I think we've got a very good and robust system in place to make sure that we are prescribing generics instead of branded drugs. So in terms of cost per unit, we have, I think, historically been much better than the rest of Wales in terms of our focus on moving on to generic drugs. We are seeing an increased trend in terms of the units of medication prescribed. But I know that the team under Chris's leadership within Jill's team are looking very much at how we manage that at a cluster and GP level, and there's a lot of intelligence that's being used very actively within that space. The opportunity probably is more for us within secondary care at this stage, and naturally Chris's background is from a secondary care background, and he's using that background in terms of moving us forward in secondary care and drug prescribing.
Thank you. I can just add a little bit to that. I think Hugh has confirmed that we have actually a very robust system to consider at cluster level and at practice level in terms of peer review. So there's a very open conversation actually around prescribing costs and rationale at practice and cluster level. I always throw into this conversation, we do look at peaks and troughs. And, you know, if we think I led the diabetes conference yesterday, which was very good to see individuals from across the whole of the system. But you know, some of the new treatment costs for diabetes are actually quite high cost drugs. But if you actually think about the impact of individuals deteriorating and not being maintained, and I would say the same for rheumatology drugs, for example, then there is a different impact on the system that we then have to consider. So it's all got to be in balance. We do hold people to account through the peer review at practice level. And as Hugh said, for a very long time, we have had a good level of understanding and commitment around generics. I think there's still more we can do around patient education and compliance and waste, but certainly working with Chris and the team and looking for the efficiencies further in terms of primary care, but also in secondary care will be key. And I think, again, as you know, the issue around some of those factors that are outside of our control in terms of drug costs are something that we continue to see.
I know Mandy wants to come in and then Rodri, and I'm going to ask everyone if they can keep their questions succinct and the answers, because we're running out, we're overrunning at the moment. Mandy.
Yeah, just very quickly on the drug issue. Yesterday we were talking about possibly undertaking a piece of work across secondary care to look at clinical variation associated with prescribing, and that's something we probably need to look at again. A couple of things on the basis, and it was Michael, your point that raised it in my mind to mention. We have already sought legal advice around some of the decisions associated with the Nurse Staffing Levels Act 2016, and on the back of that, operational services have had to go back now and rework their plans. So just to say that that is a very live issue, and it is something that is going to have an impact in terms of cost. The other thing I just want to say is that, and it probably fits more with performance, but I'll mention it in the finance space because we talk a lot about patient flow and demand, and particularly in terms of unscheduled care. But we've actually seen a continued improvement around our performance, around our 4-hour down to 2-hour waits at our front door. So even though we are absolutely log jammed, everybody is besting a gut to make sure that that continues. And that's a choice for us. We can continue to say, well, we won't put the efforts in, and therefore patients will wait longer to come in through our front door. I'm not sure that's a choice that we will want to make. And then yesterday, again, we're revisiting the alternative care options to deal with these 200 plus people that are in our system that probably don't need the level of nursing and clinical care that they're receiving. So we're revisiting that as well, together with MIU. What do we do? How do we make that much more efficient so that, again, has an impact upon our EDs? And what do we do, looking particularly at South Penn's Hospital, where we've rapidly, obviously, introduced an alternative model of care. I met with the team earlier this week, to look at their staffing levels. I've asked that there's a further piece of work done very rapidly to look at whether we can create something different there. I would say we're trimming on the edges, but we will look at everywhere to make sure that if there is a savings opportunity whilst maintaining patient safety, we will do that.
Thanks, Mandy. So, Rodri, I'm going to bring you as the last question, and then Phil to close.
Thank you. Hugh, I do like your report. And the graphs and the statistics is easy to read, yeah? Just page 7, the bar graph. I just want to have clarity on that. And I know you have touched on it. The green schemes, are they deliverable? If so, there's 6 billion savings from now until March. I just want to have that clarity, kind of how much of that is kind of, I know you said September hasn't brought the savings that were anticipated. And I'm just thinking, how sure are we of the green schemes? Obviously, things are going to change moving forward now, but looking at that specific bar graph, and because the ambers, because up until now, I think we've hit the green on every month apart from July. Are we sure we're going to hit the green? Just a quick question.
Yeah, Chair, thank you. And yes, that's the assured position at this point in time. So the left-hand side shows the amber, which has delivered. So as you rightly say, we kept pace with the green schemes at that point. On the top right-hand side, we've got the forecast delivery at 7.2 million versus the green schemes at 7.5 million. So broadly there or thereabouts, a bit more work to do to get greater assurance that those green schemes will actually deliver. Some of that issue is more around timing than the scheme itself delivering. It's just about timing of impact coming in. The challenge for us is to convert the amber into green and then into delivery, and then look at some of the red opportunities we've got and to translate those into deliverable actions.
Yeah, so first of all, great that Hugh and the team have had such positive feedback on their report, so I'm sure that's welcomed. And also, I know we've taken a bit of time over this, but I think the rounded discussion that we've had underscores the importance of how we communicate this to staff and public, so they're aware of why we're making what will be some really challenging decisions, not just this year, but probably in coming years. The ethics panel, I think, would be really open to take on some of these challenges. I think the planned care issue, I think we'd want to do that. I think it will challenge the ethics committee, but we need to do that. I think in the end, though, the ethics panel will give the advice to the board, but there will need to be decisions made. So it is important, as you said earlier, that we have the right governance in place to support those decisions. That sustainability and value group that Judith Paget chairs, the Director General, the NHS and social care, that does produce a lot of benchmarked information, some of which we perform very positively on, but other areas we're always seeking to find areas where we stand out compared to other areas in Wales. So because they could be opportunities for us. So we're always open to that. So it's an important point Michael made there. In terms of our improvement, it is good to see that there is some improvement in the run rate. Of course, it's not as fast as we'd like it. And I think there, as we've gone through the schemes, some of them there's been a longer lead in than we'd have anticipated. So there could be benefit down the line, but that will be important to us as we go into next year. And sometimes the risks that we identify when we look at the schemes, either there's too much of a patient safety risk, or it needs to be looked at in even more detail, or it might increase the financial challenge we have. So we're always mindful of that, and we are working extremely hard on that, the exec team and all the support around them. There's a huge amount of work going on around that. I think if Steve was here, I think he would point, he would emphasise the 6-month assessment that we're going to do of the position, given everything that our finance director has said. Of course, need to remember that Welsh Government would expect us to go further because it's 112.9 million deficit. So they would expect us to improve that position, and we need to just be aware of that when we make that 6 months assessment. But Steve would also say there's 6 months to go, and that will influence next year. So there's still a lot to go at. We do have a leadership workshop planned for when the Chief Exec comes back, where we will be going through things and seeking further opportunities. But thanks very much for the broad discussion that we've had.
Thanks, Phil. Thank you. So to summarise in relation to the recommendation, the board happy to accept it as it is stated within the SBAR, plus seek advice on governance from the board secretary in relation to some of the decisions that may have to be made at pace, and similarly within that advice how we refer things to the ethics committee for advice. And my advice is, it's just amazing what is happening. It's so challenging, but please keep improving throughout this year, just to gain or keep some confidence of Welsh Government in the future, as we have done with performance. So thank you, everybody. Thanks, Hugh, and well done on the new report to the team. Yeah. You know, if it's a good thing or a bad thing to see so clearly, but it's definitely a good thing. Thank you.
I hope the message can be better in the future.
Yeah, absolutely. But that's everybody's responsibility, isn't it? Okay, thank you. So the next item on the agenda, and as I say, we've read all the papers. If we can move a bit more quickly, is the Improvement Patient Service User Experience Report. And Mandy, that's you.
Yeah, thank you, Chair. As you say, we've read the report, but I think there are a couple of points I just want to pull out. One particularly around communication. 6% of our complaints relate in some shape or form to communication. I do just want to highlight that whilst that is still unacceptable, it is a significant improvement from where I sat here a year ago reporting 23%. So it's not ideal. It is an improvement nevertheless. I also want to say a really huge thank you to the family, and we've got the husband's story here, who have shared with us a patient story. It relates to obstetrics and urology, and I think it's really important that I point out that this isn't just about obstetric care. And in fact, some of the language that the husband used within the patient story, hopefully you have listened to it, is really quite difficult to listen to, but also has taught people an awful lot. And I think the carelessness with which staff use words, forgetting that for that patient or their family, it is the only time or one of very few times that they will come into contact with health services. We say things without really appreciating the level of impact that they will have on individuals. And I think this story from the husband's perspective is a classic example of that really adverse impact. There has been an awful lot of work done since this story, and it is about 18 months ago that I personally met with the husband and the partner to talk through their experience. We do have a trilogy, I suppose, if I can describe it like that. We have the husband's story, we're just finalising the wife's story, and we have a staff story as well, so that we can see it from all different dimensions, not just one particular focus. But certainly the maternity services have taken on board the learning that came as a consequence of this. I do need to go back and check with, check with the urology team as to the changes that they have made specifically on the back of this particular account, although the feedback was given to the individual members of staff directly. And I am pleased to say that the mum, the wife, has also been extremely supportive in us in terms of improving our resources and material in relation to continence care and life with a catheter, etc. So there has been some really positive learning and experiences that have come out of this really dreadful story. The only other thing I will mention, as I say, is the Arts in Health team continue to go on from strength to strength. And as was identified earlier, they are finalists in the National Penner Award. And again, I go back to, this is a team of one whole-time equivalent. We've just got them some admin support now. And what a difference this is making to the lives of our patients and our staff as well.
Thank you, Mandy.
Happy to take questions.
Thank you. Any questions? Anna?
Yeah, thanks, Mandy. And I won't dwell on communication this time around. I think my hobby horse isn't going to need a stable very soon. But I know we're going to look at communication in quality and safety, so we'll be able to provide some proper feedback to the board following that in December. But I did want to pick up a specific piece of feedback on the You Said We Did page 11 of the report. It is so disappointing to see that we are still having issues with food and drink in our A&E departments. We've been seeing this now, Mandy, for so long. Of all the things we deal with, it strikes me that it shouldn't be this complicated to be able to feed and hydrate patients who are waiting excessively long periods of time. So what assurances can we have, please, that this is not going to feature on any more of the reports that we see here?
I wish I could give you an assurance. I think previously at board, I've given assurance that we have got it cracked. We've got water and fluids in particular, patients who are there for a prolonged period of time, inappropriately prolonged period of time. So they're basically in a chair or a bed for 24, 48 hours. They do receive meals because we make sure that they are offered hot food and beverages. I was given assurance that vending machines had actually been installed in our A&Es. And on the back of some further communication that I received, that was not the case. So I apologise to board that was not the position that we thought we were in. I can, however, tell you that our procurement team, led by Catherine, has pulled out all the stops now and is making progress on that. There is some further discussion to be had about the contents of the vending machine, because we also have to think about the quality of the food and the products that are in those machines as well. But certainly that is an ongoing discussion. So if they're there for a very long time, there will be meals provided. And indeed in one A&E, they have actually looked at the role of the healthcare support worker in supporting nutrition, hydration in the waiting room as well. So lots going on there. And as I said, I will personally be visiting the vending machines now in all of our A&E departments, and I will be exploring what is there. The catering team do regularly get photographs from me about the provisions within them.
Anna, would you like that to be considered at your committee for assurance?
Yes, I mean, it has come up in conversations in QSEC previously, but I think, yes, that's a good idea, Jo. Let's specifically clock that.
Including the health worker supporting with nutrition and hydration. That should be common across the board, not just in one hospital. And it makes such a difference, particularly to the elderly.
Yeah, absolutely. It's a problem exacerbated by the very long waits. That's the change.
Yes.
And we just are not catching up with it.
Yeah, thank you. Chantel?
Yeah, just a quick, and I think some of the comments in terms of what the patients have given us feedback, I think we would need to pick that up as far as the People's Committee, in particular in terms of training. You know, we do a lot of training on mental capacity training, and yet we're seeing that doctors are talking to families instead of patients. You know, there's a whole host of things. So there's something that we need to be picking up as part and parcel of the People's Committee.
Okay. Yeah.
Just to respond, yes, and I know Amanda in our education team is linking in with the quality team around how do we pick up from this report to make sure we're targeting training to areas where it's highlighted as a problem.
Okay, thank you. If I could ask you to look at page 26, the "we did" column there in relation to a smooth transition for younger patients when moving from the support of children's to adult mental health services, and the multidisciplinary arrangements and information sharing. The actual "we did" is quite nebulous, talking about commitment and the children's ADHD and the adult services separate. And I've seen some complaints where children have fallen between two services, quite markedly so. I would just like I know a service delivery manager for neurodevelopmental has been recently appointed. Where could this be looked at in more detail? Because there isn't enough detail there to assure me.
So I believe this is being picked up through the Children and Young People's meeting that Andrew is chairing. And we have recently received into the organisation the independent review that we asked to be undertaken around neurodevelopmental services, which spans across children and paediatric services as well. But that transition piece from children to adults is certainly something that I believe Andrew is picking up through that particular group.
Okay, and where does that report to?
I'm not sure where it does actually, Joe. Perhaps you could advise.
Chair, I've just made a note that we need to make sure that feeds into an assurance committee. So I think we need to have a bit of an action of the outputs of that group need to go somewhere.
Yes, please, especially that particular area, because it's renowned throughout Wales being an area of challenge. And the fact that the response is so vague, we need more detail there to get assurance. Okay, thank you. Any other questions? Okay, everybody happy to note the report? Great to see the improvement on communication. Amazing. It's an ongoing challenge, what we have to, I know. So we also agree that the A&E refreshment issue will be considered in more detail by the Quality Committee, and the training of people in relation to learning disabilities, etc., by the People Committee, and action on the children's group. I think, Del, if you were a member of that group, weren't you? It goes into the formal committee system, so we can scrutinise particularly the area of transition. Yeah, okay. Thanks, everybody. So the next item on the agenda is it's you again, Mandy, it's the Ombudsman's annual letter.
Yeah, so thank you for that. And again, I'll be very brief. Just to highlight that whilst this isn't the report that I would like to be presenting to you in terms of aren't we great, because we're not, there's still more work that we need to do around the number of complaints that get referred on to the Ombudsman. I would say it is 4% of all complaints that we handle. So just to put some perspective on it, the high intervention rate that's being called out within the report and the letter to us is a piece of work that I've had some conversation with the Ombudsman's relationship officer, because I'm keen to understand why is that happening here. We have improved our early intervention with complainants, but I still think that there's more that we can do there. Just to note the recommendations for us to review our resources available to the complaints team, review the compilation of complaints data, and considering independent medical advice to support on a case-to-case basis. Again, just to say there that we do already look to source independent medical advice where we feel it would be advantageous at the early stage before it's even gone to the Ombudsman. So we do look to have that. There is a response due by the 1st of December, and we will be on track to make sure that that response to this report is provided. I think it's just disappointing that the Public Service Ombudsman has, it's called the report Groundhog Day 2, and it does feel like Groundhog Day, because I sit here and, 40 years in the NHS in November, not quite yet, and I look and I think it's all the same stuff, despite the listening and learning, despite the work that we're doing. And I do think there's further conversation we need to be having with our education providers at the pre-registration side in particular, to help them understand the value of engaging at that earliest opportunity, having honest conversations with people and being clear about the communication that's had, because that's often where we need to be doing more work.
Thanks, Mandy. And are we having that conversation with the education providers?
We do work through the, we have got an education liaison meeting as well, and these sorts of themes that come up are always fed back to them so that we can make sure that in the curriculum, so if you look at the quality improvement piece, for example, that is now built into the pre-registration curriculum. Medical staff, I would argue, probably have laboured on the communication piece a lot earlier in their training than perhaps some of the nursing colleges. So it is a conversation I will be picking up again with our education providers.
Thanks, and you can leave that as part of your legacy.
That'll be my legacy.
Absolutely. Yeah. Any more questions? Maynard.
It's a comment more than a question. I think whilst seeing the 41% featured in the report, when you actually look at the statistics, we have the lowest level of complaints apart from Powys in Wales.
Yeah.
And I think that's quite significant. So we're actually looking at 41% of a lower number as well.
Yeah.
Thanks, Maynard.
I'm glad you said that, not me. Thank you.
Okay. Thanks, everybody. Everyone happy to accept the recommendations? Thanks, Mandy. And next item on the agenda is the Integrated Performance Assurance Report. Hugh, it's over to you.
Yeah, I'm very conscious, Chair, of time, but I'm also very conscious that while we present statistical information, there is a patient at the end of each of these statistics. So I don't want shortness of introduction to represent or to be misrepresented as being a lack of interest in the patients who are facing delays in care by us. Some good work being done in planned care to recover our position, but I would highlight that there has been a increase in the breaches in the metrics apart from the RTT weights over 104 weeks. These are in line with our trajectory, and I guess a hallmark of our position has been one of transparency. We had not assumed our trajectory was not dependent on receiving any additional planned care recovery funding. So we are being very transparent and consistent between the finance reporting and the performance report. UEC still very concerning, both 4-hour and 12-hour, showing deterioration in August, and ambulance handovers showing concerning trend as well. Cancer, there has been a focus on reducing the cancer backlog, and naturally that has an impact on the performance metrics that we are looking at. The overall backlog of weights in August was 426 patients against a trajectory of 311. Some real challenges for us in urology, lower GI, skin and lung cancers. One area to highlight and to pull out, Cancer Research UK funding has been used to work within prostate cancer with a pilot on straight to testing on MRI, which is proving really positive and rolling out further over the next few months now. Bronglice from July and Withybush over the autumn. Mental health, we know the challenges within mental health. They've been discussed in a number of forums now. Diagnostics, still a real concern there. Breaches substantially increased in August. Particular challenges around radiology and cardiology in particular. And therapies, we've seen a very steep rise in month-on-month breaches, particularly in physiotherapy, audiology and dietetics. Dietetics mainly linked to weight management services. Interestingly, not an area that is a ministerial measure that we are required to track. So we'll be looking at how we track the therapies weights to distinguish between those that are ministerial priorities and those that we would want to track internally. So that metric may change in future reports. Healthcare acquired infections, I'm sure the Director of Nursing would be very cross if I didn't highlight that we were continuing with good performance there. There has been a deterioration in August, but that's a fairly consistent deterioration with other health boards as well. And we may remain on that trajectory for a 20% reduction. Jill, I'll leave it there and open to questions.
Thank you. Keith, could I ask a question about ophthalmology, please? I noted it in the Chief Executive's risk register, very high risk, and the reference to the regional solution. Where are we in that? Because there's a number of reports. Ophthalmology for me is standing out.
Thanks, Chair. There's a closure report due to go to the next regional recovery group meeting in a week or so's time that closes off the current schemes in respect of cataracts and glaucoma, but then proposes a new refocused approach for ophthalmology more strategically, given the underpinning and inherent challenges facing the service, particularly around workforce recruitment. So a lot of those improvement programs under the previous regional program were very much centered around and geared around workforce development and recruitment, which has not been forthcoming to the extent that we all would have wished to see. So there's a proposed re-profiled and refocused approach being considered by the Regional Recovery Group in a week or so's time, which will then clearly need to take account of some of the work that's emerging nationally. There's another national report due by Christmas, and we're expecting to take account of the messages from that, also from the recent GIRF reports that each health board has received. So what that means for us organisationally in terms of the direction we may need to consider is probably a conversation for another day. But clearly there's an emerging clinical view around what that might mean for future configuration of services, for example, in order to promote and have a more positive impact on recruitment potential. So we'll need to bring that back through board once that's a bit clearer.
Okay, so it would come to board, not a committee?
I think it'll probably need to come through the subcommittee structure, but ultimately,
Okay.
I think given the if the outcome of that process is going to be sufficiently significant, then I think we will probably need to bring it back through board as well.
Okay, any idea when it might go to ESTOP?
Well, the national report is due by Christmas, and clearly that regional work is going to need to take account of that learning and that feedback, because I think it would be incongruous to take a slightly different approach.
Okay, so a couple of months after Christmas. Yeah, okay, thank you. Any other questions? Chantal?
Just a couple of questions around the ambulance. One, in the report it says that 90%, when you diverted it to same-day emergency care, 90% of those patients would have been discharged. I'm just wondering whether we've done a piece of work with the Welsh Ambulance to see whether these should not have been conveyed in the first place, or whether they could have dealt with it in the community rather than bringing them into hospital and having to create that diversion. The second question was around the 4 hours, where the delay in the handovers rather, and whose responsibility it is to look after the patients when there is that delay in terms of the handovers. Is it our responsibility, or is it the responsibility of the paramedic looking after the patients on our premises?
If I start and then hand over to Keith. So in terms of whose responsibility it is, I'm very clear. Once the patient has arrived and been clerked in, handed over, i.e. the patient's here, it is our responsibility. That doesn't mean to say that our paramedics should abdicate all responsibility in terms of supporting the care of that patient if they are unfortunately unable to be handed over. But we are responsible, and as a consequence of that, our staff regularly go out into the vehicles, assess, and treat patients on the back of those vehicles as well. Not desirable, that's if we can't hand over the vehicle. But Keith, you may want to pick up.
Yeah, thank you, Mandy. And that's an important point, because that care is then managed jointly between both the paramedic crews who attend to those patients and our staff who regularly provide care on the ambulances if that is required. So that is a very clear understanding between both our own staff and the way in which our paramedic staff who attend our departments work. I probably just would want to add, and it's important for us to reflect as a board in a way. There's clearly been a dip in the performance in the last reporting month, but if we look at our 4-hour handover performance over trend in recent months, there's a very discernible trend of improvement. And I think that is noteworthy. There are a number of factors that have conspired to play into the outcome through the month of August, but it's particularly noteworthy, and I was celebrating this with the Glangwili team in particular last week, that the reported extended, the 4-hour plus handover delays in Glangwili last week were the lowest we've seen for 2 years. And I think that's particularly noteworthy as just another indicator, if you like, of the gradual impact that our broader urgent and emergency care improvement plans are beginning to have. It's very variable. It's never a straight line improvement, but we just need to bear that in mind in terms of a wider consideration when we look at some of that data. The earlier point around the patients who are referred directly into to SDEC and then discharged. Yes, we do audit our SDEC attendances. We have seen a significant increase in SDEC referrals and attendances over recent weeks and months. And part of the audit work we've got ongoing that underpins all of that is to ask ourselves the question, well, was there another opportunity for some of these patients anyway, so that they even need to come through our SDEC route? And that, of course, very much mirrors with our broader clinical streaming hub ambitions that we wish to embed and develop as a health board over the period ahead, because ultimately that's about making the right choice for those patients at the point of their presentation, wherever they present. Yeah. So I'm sure we'll be able to bring some harder data around that once we've built up a sufficient data cohort that can justify that piece of work.
Thanks, Keith. Any other questions? Michael.
Just ask a question, again, being a bit of a new boy here, just on primary care, is there, what is the possibility of getting some sort of dashboard to get a feel of the temperature of primary care generally? I mean, GPs and pharmacies and stuff like that. I actually asked this question at Cardiff and Vale, and they said, well, it's really difficult, but we'll have a look. I just wonder, where are we on that kind of dashboard?
Out of hours, yeah.
Yeah, things like that.
I think Cardiff and the Vale had one. Yeah, but they couldn't compare it across Wales because nobody else did, or at least wasn't in a board paper. Yeah.
I can respond. I mean, certainly in terms of access, we are expected to have an access committee within our health board, which reports then into SDOT, and we do that because there are contractual standards really in terms of how patients access primary care services. There's a conversation actually starting this week with Welsh Government for IPQD metrics for primary care. It's something that's absolutely recognised in terms of how we create measures that we can compare across Wales. It hasn't been defined in the way that we would like or can do easily, but hopefully that's the start of conversation on a national level. It's going on individually with each health board, and then there'll be a coming together in terms of the information that we can bring into that domain.
Hugh?
And we do like a challenge. And I'm very conscious that one of the consequences of having an increasing number of managed practices is that we become the data owner, and Jill's team has got some formidable business intelligence now through Power BI and the dashboarding capability that we've got in the health board. So it may be that we can pull some of that operational data where we directly manage services together, as well as, I think, as part of our long-term digital strategy, having a regional data fabric and understanding is definitely part of our trajectory and part of the work we want to do.
And we're happy to share that Power BI presentation in a board seminar or something, but it's certainly a conversation we're having then with the LMC and other practices about extending that data collection elsewhere. That focuses primarily on GMS, but we've got other information that we're looking at as well.
So to be clear, we're going to develop this at the pace of the national development.
Well, we are leading the way in terms of the Power BI work that we've done with our managed practices, so we're committing that. But certainly Welsh Government, with the strategic programme, are leading the IPQD position in terms of national measures. And I think, not to be challenging, but there are contracts in place and things that have to be considered really in terms of what's agreeable across the professions as well in terms of measures that might be used to compare performance in terms of delivery and outcome.
It might be worth having a little look at what has been reported over many years in the board papers in Cardiff and the Vale and primary care. Just might be worth looking at. Okay. Keith, you mentioned it's the lowest in 2 years with the handover. Does it actually say that within the report?
So that obviously lapses into the September report, so we'll need to reflect that in the September report. But it's just a reflection of the overall trend that we're seeing.
Because it's really, this report is, honestly, I was reflecting last night, it's come on leaps and bounds in the last 4 years. When I first came in, it was something like 113 pages long, and you couldn't see the wood for the trees. It's much, much better. But those, nuggets about the actual improvement over the last 2 years. And you very kindly gave me some of those nuggets last week when I had my appraisal, because sometimes when you're reading so much data across so many services, it's hard to pick that out. But it's really important as well, because we've also got to celebrate and give hope that, you know, measures that we have been put in place, they're actually making an impact.
Indeed.
So that'd be great. Thank you. Looking at the report, we're asked to take assurance from the IPAR. I think we can take assurance from the data that it presents, but I think we have to note the performance, because we're not where we need to be in, you know, a number of areas, if that's okay as the recommendation. Everybody happy to accept that? Okay, thanks ever so much. Next item on the agenda is the operational update. I assume it's you, Keith? Yeah, and Jill? And I'll just reiterate, we have read it.
And so, absolutely, we're not going to go into the detail, but I'm going to make one point to update, and then I'll ask Keith if he'd like to touch on anything around plan care, because we've already touched on urgent emergency care. But I just wanted to give an update to the board in terms of where we are with the COVID vaccine programme. There aren't any numbers in the report that you've received, but we were asked to accelerate that by the Welsh Government due to the issue of concern around the new variant. So we were asked to bring the start of that programme forward to the 11th of September. We've got 43 practices and 12 community pharmacies participating in the programme, and 33 of them were able to start on the 11th of September. All of the practices were able to then start on the 18th. And obviously the ideal position that we'd wanted to work towards was being able to deliver COVID and flu together. So just in terms of numbers given of COVID vaccine so far, it's over 5,500. We're waiting to update WIS a little bit more, but clearly the priority groups that we've been asked to start with are care home residents and the over 75. So I think really good progress made to date. And we are really grateful for the commitment of primary care. We will do a mop-up exercise with any MVC activity should we need to, but we've got a lot of engagement for primary care in this delivery. So just ask Keith if he wants to raise any points.
Thanks, Jill.
Thanks, Jill. Yeah, I won't dwell on the plan care or service-related elements, because we've covered those in some depth in the conversation so far. Probably the main issue I probably want to highlight, being very mindful, I think this is the first public board we've had since we escalated to internal major incident status, is just draw colleagues' attention to the update around the RAC position in Withybush, which we're all aware of. I'm mindful. Thought it would be important for us to share the structure and the command structure and the terms of reference around those supporting groups, and they're in the paper for information for members' awareness. Also mindful that this update is obviously written at a point in time, and each week the situation moves on, etc. Just probably want to highlight that we continue to monitor very closely the impact of the RAC mitigation measures that the team so wonderfully worked together to put in place on our overall quality and performance impact through the not just the Withybush but the Pembrokeshire integrated urgent and emergency care system, and we continue to monitor that on a weekly basis. I guess the next staging point for that now will be the anticipated return of the first of the repaired wards, and that's Ward 9, and that is due to be returned to operational use in early or mid-October. And we have taken a decision to utilise that area as a medical ward area in the intervening period whilst the remainder of the repair work progresses, to help alleviate some of the additional pressure that the mitigation plan has inevitably placed on the front door at Withybush, because we can see that we have seen a deterioration in ambulance handover performance in particular as a backdraft consequence of everything that we've had to do. So, and we will continue to monitor this and continue to report it as we go through the autumn.
Thanks ever so much, Keith. I've also received some patient feedback. Everyone is doing everything they can, but I just think on behalf of the patients and the staff of Pembrokeshire, it's a disgrace that we have a hospital in that condition. And it'd be even worse if it wasn't for them, but we deserve better. It reminded me of Andy Burnham and the H2, what's it called, the high-speed railway, second-class citizens. And I shared with Phil, I was in Southmead Hospital in Bristol on Monday. What a different world. What a different world. And all I could see was the props and the closed wards and the people having to have their treatment in an environment which isn't dignified and is unacceptable. But a massive thank you to you, your teams, and everyone that's doing it. But we deserve better in West Wales. We really do. Phil?
Just to, I mean, I absolutely want to emphasise what you've said there, Chair, but also that the work we're doing, of course, just to remind us all, is only to deal with the red issues that have been identified by the contractors for RAC. There are a whole load of other issues that of course, the funding which we're grateful for from Welsh Government, but that won't address all of the other issues. And the work programme to deal with the red rated issues actually stretches out over into 2025, I understand, at the moment. So it's a really significant issue, and the staff have been amazingly creative in the way that they've changed adaptive services, and I think the public have been really patient and forbearing through this period. The other thing I was going to say is that we've continued, we haven't stepped down the command structure that we have in place. You'll see that's in the paperwork. We're continuing with that. We're still in contact with local authorities around mutual aid, and the situation is still serious. So there's all sorts of things still to work out, which is why I think we still need the command structure in place at the moment.
Thanks, Phil. And again, this report is another report that's really clear, really well written, and gives us a picture of how things are at the moment. There's one issue in there that I don't feel assured on, and it's the trusted assessors. And that's predominantly because one of the biggest challenges we have are those poor patients who are in hospitals and shouldn't be there, which has the knock-on effect to the A&E, to ambulances getting out to the community, to poor patient care within the A&E departments, and you know, the hydration and the food. And the summary of the trusted assessors, I am not assured with the Ceredigion summary at all. So I just wondered if we could have one of our committees can scrutinise the implementation of the trusted assessor, which was one of the ways to get people where they should be cared for in a better place. I don't know whether it's quality and safety or SDOC or people. Can I leave you to outside?
Table of actions, Chair.
Table of actions, yeah. That really needs to be dug into what's happening there, because it's one of the greatest challenges we have, is to assess people to help them get out of hospital and provide the care. Any questions on the report?
Yeah.
Judith?
I'll start with that one if I may, because I and Keith knows this because I've expressed frustration SDOC. I cannot understand why, when you've got a national definition, we have to have 3 completely different ways of implementing the same thing. So I'm very frustrated. I know the staff on the ground are. So I'm not sure it should go through people, if I'm honest. I think it's a quality issue in respect of in respect of the services our patients are receiving. It is discussed in the integrated executive group, but there's been choices made as to why you implement it in a different way in a different locality, which I can't get my head around. So I would welcome that extra scrutiny. The one thing I wanted to mention was about ROC, and I won't repeat everything that has been said about how incredibly hard everyone's worked. My concern, I guess, is almost, I hate to use this phrase, but I can't think of another one, a long ROC, that this is not, this has the potential to create ongoing pressure for our staff, having to continue to deal with treating people in that environment, but also what moves may be needed in the future. And I'm not saying we can avoid that, but I just think if we could find a way of capturing it, because I think it adds to the pressure we maybe can bring around decent facilities for this part of Wales, which I agree with the Chair in terms of your sentiment. And if I can, anecdotally, I can remember discussions when I first came to Wales about the services at Cardiff Royal Infirmary, and someone actually saying, why are we putting up with this, trying to fiddle around the edges to keep something going. And I just think there is something about building up that picture, because those staff are going to have to deal with that situation for some months, years to come, and it's just not acceptable. However much we support them, which we are doing, and everything that's going on, but it just feels like it's just needs emphasising again and again.
Thanks, Judy. Any questions on the report? Maynard.
Two of the three questions.
Okay, please.
We can address all what we've been doing.
Okay.
I noticed the significant improvement on outpatient appointments and the ones running over the follow-ups and over 100%. And we're using SOS and PIFU on those. I'm just wondering, as well as the organisational side of it, which is what's reported here, whether there's been any clinical feedback on the outcome of using those methods?
Oh yes, so thanks, Maynard. But there's an increasing level of clinical buy-in to those more transformative ways of delivering follow-up assessment care. And we've got something over 26 specialties who are in some way, shape or form involved in the SOS and PIFU type models now. I mean, and it's very much centred around that. That's the predominant driving force that's enabled our continuing reduction in those longer delayed follow-up reviews. But it's also enabled us then to switch that capacity to address the new waiting patients. So there's a tangible benefit on both sides of that, which is really critical. But we've got a number of lead clinicians across a range of specialties who very much champion that approach within their respective areas, but we also use them then to encourage their colleagues in different areas. Yeah, so it's very much the approach we should be adopting. The point I probably want to draw out from that, though, which is really important for us to consider, is in parallel with that, we've managed to improve to a place where the majority of our clinical body are very judicious in their clinical decision making early on in the patient's presentation. So our discharge rates after that initial assessment are very high. So when we combine that element with the volume of patients who are going through those SOS and PIFU pathways, we're achieving some very positive numbers. Again, I think it's noteworthy for us to reflect that as a health board, we follow up a lower proportion of our health board population than any other health board in Wales. And there are some health boards where that's double our proportion. We run about 16, 17%. And that's because of that clinical approach that our teams have adopted, albeit catalysed by the pandemic and the experiences through that. But some of those changes that have been adopted have been sustained since that period and now become de rigueur, if you like.
Okay, thank you. If the board could have a look at the recommendations, because we're asked to receive the operational update and progress report and ratify the decisions in 1 and 2 in relation to the Goal Command Group. Are the board happy to do that? Thank you. And also, another recommendation is that the trusted assessor role is considered in at one of the committees, and that conversation can take outside. I'm not going to make a fourth recommendation, but I think what we should have there is a massive request for the accelerated delivery of our new hospital. As it happens, I understand, in England in relation to those hospitals particularly affected by RAC. Okay, thank you. So the next item on the agenda is the clinical services plan update. That's Julie.
Yeah, yes, thank you, Chair. So I'll be brief, as I say, we've in our time. So we've already had an update, of course, on the primary care work stream, so I won't cover that. Mainly the paper is providing an update on the work that's ongoing to collate all the key information necessary to produce the issues paper that we're working on, including early targeted intervention engagement. Sorry, the paper does note that whilst all the projects are established and groups are meeting and so on, the current issues we've experienced with the RAC situation that we just mentioned, plus the financial pressures we talked about earlier, have disrupted the rhythm of some of those groups to some extent. So that does present us with a bit of a risk to the aim that we had to bring the issue paper to January, but we're worst case scenario, that would come back to board in March, but obviously we are still trying to aim for that January target if we can. There is a brief update in the paper on each of the service areas. The most advanced is, of course, the paediatric services, and the paper describes that where we got to with the public consultation, which is now closed. A report will come back to board in November. Just one final point to update board members on. In the last week or so, I've had a letter from the Consultation Institute on the 4th and 5th stages of their quality assurance process for that consultation, and they've confirmed their satisfaction with the process to date. And there's just the one stage remaining now, which will be the final report that the board will receive in November. So that was it for me. Happy to take any questions.
Thank you, Lee. Any questions? Anna?
Chair, I wonder if I just might just simply share an observation. I think it's just worth us being really conscious that this process is the responsible thing to do in the face of a whole raft of very fragile service pathways for our communities. And while we are trying to ensure that what we're doing now is not going to interfere with our longer term strategy, it is not a substitute for that longer term strategy. And if there is any expectation beyond this room that might be the case, we need to disabuse people of that very, very quickly.
Thank you, Anna. That's really helpful. Thank you. Phil?
Yeah, I think that's a really important point, because actually if any of the kind of service changes that might come out of this were the right service changes for our population, then that would have been the result of the consultation engagement exercise, clinically led with our staff and consulted with our public back in 2018. So changes that we have to make in the interim, there will always be some compromise in that, and there'll be consequences to it as well, which we'll need to be really clear on. And sometimes I think, particularly with professional bodies that represent a specialty, a very compelling argument for a change to one particular specialty is made. But when considered within all the interrelationships between other specialties, actually it's much more of a complicated issue. So we'll be tackling all those things, but thank you for the comment, Anna.
Okay, any other questions? No? Okay, everybody happy to note the progress and the programme timeline, and it may, because of all the other pressures we're under, it may be March rather than January. Thank you. Next is the Corporate Risk Register.
Yeah, thank you, Chair. So, as members will be aware, the Corporate Risk Register provides you with an overview of all the current corporate risks that we're currently carrying as an organisation. We last presented this to you in March 23, and as you can see, there are 22 risks there on the risk register now, with 6 being new, 2 have closed, 2 have increased, and 14 we've had no change in position since March. So, and just to note that 3 of the risks that are contained within those 22 we can't discuss in the public domain due to the sensitivity of those risks, but they do relate to radiology, cybersecurity, physical security of the sites. I'm not going to go through the risks in detail because they've all been discussed in the various committees, Chair, and reviewed, and also prior to going to the committees reviewed by the Executive Risk Group. But of those 6 new, we've discussed those this morning. We've got RAC, ophthalmology, radiology, primary care has already been mentioned. The only one which has slightly is in relation to the capital, so again related to RAC. So if there's any questions on any specific risks, Chair, they will be to the risk owners, but that's the update since the March meeting.
Thank you, Jo. Any questions? No. Thank you. The board's happy to take that it has sufficient assurance that they're being assessed, managed and reviewed appropriately, effectively through the risk management arrangements in place, noting these been reviewed at board level committees. Yeah, thanks, Jo. The next is the laboratory, can't even say that, information network, Cymru link update, and that's you, Hugh.
Yeah, Chair, thank you. I'll pick this one up there. If I may, Chair, I'll cover this and risk at the same time, in the interest of time. I have much sympathy with colleagues in DHCW, Digital Healthcare Wales, who are trying to address a legacy challenge here in the way in which these programmes were previously managed. The two reports are here just to note and receive. We've had numerous conversations over time on them. On Link, we are now continuing with our existing supplier InterSystems and upgrading the system that's being provided. We've shifted our position on this to move from being last to go live to being first alongside Swansea Bay. So we should be in a position to go live on the 28th of February 25. And there's a financial gain for us over the period of the contract of 190,000. So that's just to note at this point in time, and we'll track and monitor the risks of delivery or as part of our normal programme management arrangements. On RISP, I've brought this into the private in-committee board in previous meetings, just to bring this into the public space now and recognising, and I think the table on page 2 into page 3 just shows the complexity that's being managed here, and the financial quantums that have been involved have been moving around very significantly. But if we're at this point in time, we're now looking at additional costs expected over the period of £135,000, which compares with the original board paper back in April of £275,000. And over that period, we've had a significant change up and down in that position. Chair, happy to take questions, but we'll now manage this as part of our normal programme management arrangements.
Thank you. Are there any questions? We have debated this before. No. Thank you. The board's happy to accept the recommendations in both reports. Thank you, Hugh. I'm going to go on to the provision of NHS primary care personal dental services in North Pens and Ceredigion. That's you, Jill.
Thank you, Chair. This is an important paper that we're bringing to the board today for approval. We would need to be bringing it anyway in the case of the actual cost we're considering. It will require Welsh Government approval as well. But I do need to say that in the light of all of the challenges that we're facing, we've had some previous discussions through our executive team and through CDG, because this was one of the issues that we placed in that 30% box when we were considering some of those things that we may or may not do across NHS Wales. And it would be a very, very difficult decision, but in our 30% box, which would probably require ministerial approval, we know that dental services are a priority. We did question whether or not we would proceed to bring this paper forward for commissioning or for the recommendation to commission in the light of the financial challenges that we face. We have to let 10-year contracts in terms of dental services. So over a period of 10 years, this would be 7.9 million that we were considering. However, if we did not commission these services, you will note that there would be a further 13,000 individuals who currently access services within these contracts that would be affected. They would either have to find another practice to register with, go privately, or possibly not have a service that, and then possibly access urgent access. So we considered that in the round, and we believed that it was very important to bring this to the board today in the light of the impact on patient care. You will see also in the paper that we're already running at a lower level of our pre-COVID access to an NHS dentist in comparison with that. And I can say to you that even with the contracts here today, I know of at least 3 others that have come into my inbox which have also been terminated, that are not before the board today, and terminated for the reasons of workforce and contract reform and other things. So there is a real concern around access to NHS dentistry at this point in time. We had, as we are expected to do, gone out for expressions of interest just to see if there would be any interest if we were to move forward in that procurement process, and we believe that we would be able to find providers for these contracts if we were to proceed through the process of procurement. So we're bringing them to the board today on that basis. We do acknowledge that if there was any change to the board's position, we would be able to halt that process at a later date. But I would feel that we'd be disingenuous in terms of engaging providers in a lot of detailed work that they have to do to go through the tender process, to put themselves forward, to come forward for what is essentially an interview or a panel process around the detail, and then to say, well, actually, we're not going to proceed, would be quite difficult, both also for providers, but also for the public. So in the consideration in the round, understanding the financial issues that we face, but also the health needs of our population in terms of accessing this important service, we believe we would like to recommend today that the board does accept that we proceed with the procurement process for the contracts that we've identified in the paper.
Thanks, Jill. And if I could ask the Director of Finance what your view is, please.
Thank you, Chair. We have had a robust debate about this, and continuing to proceed to market, I think, is sensible. It's not a commitment at this stage, and it may well be that by the time we reach that point of commitment, there'll either be some clarity from national discussions on the opportunity we need to pursue, and in any case will be far later on in the financial year. So I don't think it's necessarily something that will affect us at this point in time, but we do need to bring back at award stage so that we've got some clarity on the implications going into next year.
Okay, thank you. Any questions at all? Judith?
Can I just ask you, you mentioned that you may have others in your inbox. You have others in your inbox. How can you evaluate how much is this to do with the new contract? And also, are we seeing a different situation here than in other parts of Wales with this?
I mean, this has been a really significant concern. Now, first thing I must say, because there might be Welsh Government and others listening to me, I mean, the new contract was intended to target patients who are in greatest need. So I think everyone understands the principle of ensuring that we don't just count the current units of dental activity, etc., but we really try to get to people who have need. And I think everyone applauds that. The challenges have been trying to deal with new and historic patients, workforce challenges, and other things that have affected this. And the monitoring that goes on, a very complex way at this stage of how providers then recompense their use to the old traditional way of units of dental activity. So we're not in a different position across Wales, but as I say, and yesterday the contract, the notice of termination, so it will terminate in a few months, but that 6-month termination process will start, was on the basis in my inbox of they cannot continue to work under the current or the new contract reform process. So, and then 2 others that came in last week, similar workforce challenges. For some of the big providers, they were also used to being able to recruit from Europe more than we're able to do now. So some of our big corporate companies find that a challenge in terms of being able to provide services in rural areas. So a combination of factors, but something that we know we will continue to, and we have directors of primary care coming up. This will be a continued conversation with the Chief Dental Officer in terms of how we try to improve that situation. And working closely with the dentists, sorry.
That's really helpful. I wonder if I could suggest that this is something that, well, it won't be me, but is taken forward through the vice chairs. We have had conversations with the minister. I know there's a ministerial meeting coming up. I think for vice chairs that we do raise this if this is an issue affecting us, and take advice from our directors to have some collective conversations about it.
I wonder if I could also have a briefing for the Minister, please, because she did raise it with me last week, and I promised a direct briefing update, and it would be helpful.
We've had that request, Chair, and it's on its way.
Okay, thank you very much. Based on a very, open discussion, is the board happy to accept the recommendation to approve the procurement process? Yeah, thank you. Thank you. Next item on the agenda are the annual reports, and the first one is the Strategic Equality Plan annual report. Lisa, that's you.
Thank you very much, Chair. So these are a series of reports that need to come to us as part of our equality duty. I would just like to say they have already been through our BAME advisory group, our staff partnership forum, and they've been in discussion at the People, OD and Culture Committee. So there have been quite extensive conversations around the detail within the reports. The reports are just a statistical analysis of our workforce. So a conversation I've been having with colleagues around the table really, how we're going to start to bring this to life this year and have some stories about what are people's experiences that will then help us dive into the data to see if anything is being masked within them. So I'm certainly working with Anna, who's going to help us to do that this year.
Great. Thank you. And you did raise it at the Bain Board Advisory Group, and they were all up for that as well, so thank you. Any questions on the report? I was looking forward to seeing the next iteration. So, yeah, the board's happy to receive it and approve it for publication. Thank you. Then we go to the assurance. So the first one is the report of the Sustainable Resources Committee, and that's Winston.
Thank you, Chair. I just want to bring the board's attention to the Madison report. I think we can note that the contents of the report, we have a meeting in August, just want to bring the board's attention to follow. So we had insufficient assurance of the £113 million deficit. I think we've heard of that and heard the reasons for that earlier in this meeting. I think we highlighted the need for continued engagement of clinical teams in the delivery of safety and efficiency programme. I think we felt it was really important that we had more evidence of clinical engagement. I think that relates to what we discussed earlier. Is that well on the voice? Good. And I think we had some positive assurance on the work being done on the value-based healthcare team. It's unfortunate that, as earlier we heard in the report in this meeting, that we're going to downscale that. But it was important to note the really good work that they're doing. And finally, I think we also noted the challenges in relation to the increased demand for urgent care and the inadequate flow and use of community capacity. That was something that came up at the last Sustainable Resources, which we will go back to, I think, in future meetings. So that's all I wanted to bring to the board's attention.
Many thanks, Winston. Are there any questions? Okay, thank you. The next item on the agenda is the Strategic Development and Operational Delivery Committee, please.
Thank you, Chair. The last meeting actually covered an awful lot of the items that have already been discussed on the agenda. And when you look at the issues of concern, lack of ophthalmology capacity, discharge update report and trusted assessor model, we've already talked about, the scrutiny of digital programmes, the performance challenges due to rack work and our financial performance. I don't think I need to add anything to what's already there.
Thanks. And we've discussed most of that today, haven't we? Any questions at all? No, thanks everybody. And then the next is the report of the People Committee.
Thank you, Chair. The last committee meeting was chaired by Judith as I was away, but I would be happy to take any questions raised in the report. Just to highlight the one risk that was, the new risk that was added to the DATIX register that was in relation to pre-employment checks. But other than that, I'm happy to take any questions or whether Judith has any other comments to add to the report. Okay, thank you.
Chair, can I just make a comment on the pre-employment risk? Because there was a bit of an issue with that not following due process before it had got there. So I don't think the risk is as is, just to assure members that I don't think you'll see that in people going forward. We just need to work the releases team. So apologies, there was a bit of a glitch in the system with that one.
Thank you.
Thank you. And thanks for the report. Next is the Health and Safety Committee, Judith.
Yeah, thank you. Again, the report's here as read, and as you'll see the areas that we discussed. I should just say in relation to RAC, because of the health and safety implications under the Act of this, we will continue to monitor it with that focus. Obviously, it's also going to in other areas. I think the area of concern that I would particularly highlight is relation to security. And you'll see the detail of some of the concerns we had in relation to that. But I've nothing more to add, so happy to take questions.
Thanks, Judith. And your committee, or that committee, will keep scrutinising the security management.
Absolutely.
Thank you. Any questions? Thank you, Board. Happy to receive it. And then we've got the committee update reports. There's a number of those there. Are there any at all that we need to specifically approve or draw attention to?
Just the in-committee board reports, Chair, because I know Hugh's already taken us through the link and the risk items, but the in-committee board did approve those due to obviously commercial sensitivity. So we just need to make sure we've ratified that in public. And the others are just updates from enumeration, mental health and stakeholder reference group and staff partnership forum, Chair.
Thank you.
Information.
Thanks, Joe. Board happy to ratify that and receive all these reports? Thank you. And then the next one are the joint committees and collaboratives. Is there anything specific in there that we need to approve or ratify? No. Board happy to receive them? Thank you. And then the statutory partnership update. Jill?
Yeah, nothing to add. Thanks, Chair.
Okay, board happy to receive them or receive it? Thank you. And then the board annual work plan. Okay, that brings the public meeting to an end. Diolch yn fawr iawn, everybody.
Sorry, Chair.
Sorry.
Yeah. Was just rightly pointed out as we whiz through the joint committee
Okay.
updates, we do actually need to ask board members to approve the changes to WISCs and ESC standing
Sorry,
orders.
thank you.
Sorry, I
Did read
apologise.
that.
And also
Yeah.
to the changes to the financial limits for the IPFR requests. There is on page 2 of the papers, there is a request for board approval there.
Okay, board happy to approve those. Yeah, thank you. I'd also like to announce just before we end that the chair's post has been advertised for Hywel Dda. So if you have anybody who would be interested, can you please encourage them to apply? So thank you very much. So this open board meeting has come to an end. Diolch yn fawr, everybody, and we will have a short break for lunch and reconvene for the in-committee session in about 45 minutes. Is that okay? Thanks, everybody.